a full agenda, so we'll go ahead and get started. I'm going to ask Luann Southern to take roll, and then we'll get started.
Dr. Babatope.
Here.
Dr. Chapa. Dr. Farmer.
Here.
Sonia Gaines. Dr. Goodman.
Present.
Dr. Ibrahim.
Here.
Trina Ida.
Present.
Andy Keller. Dr. Lakey.
I am here.
Dr. Liberzon. Dr. Martin.
Here.
Dr. Martinez.
Here.
Dr. Maxwell.
Here.
Dr. Mayer. If I saw her.
Here. It's
Doctor-
yeah, sorry, go ahead.
Dr. McCullum Smith.
Here.
Dr. Mitchell.
Here.
Dr. Nemiroff.
Here.
Dr. Newport. Brittany Nichols. Dr. Olvera. Dr. Pliska.
Here.
Dr. Podewelts.
Here.
Scott Schlacklin. Sue Shell.
Here.
Welcome.
Thank you.
John Scott.
Here.
Dr. Suarez. Dr. Taminga. Dr. Thompson.
Here.
Dr. Vo.
Here.
Dr. Wagner.
Here.
Dr. Wakefield.
Here.
Dr. Williams. Thank you.
And the total?
$22.
22. So we are at quorum. Again, thank you everyone for being here. Yep. Okay. Very good. We'll go ahead and get started. But we wanted to, before we start though, we have a couple of new people that are part of the executive committee and just wanted to recognize those individuals as their first time being part of this group. Trina Ida, thank you for being here. You're a familiar face with this group. You presented to us before and appreciate you being here. Lee Johnson, I think, got pulled into another meeting, so he isn't here. Dr. Renee Olvera, the chair of the Department of Psychiatry and Behavioral Sciences at UT Health Science Center, San Antonio. I don't think he was able to join us yet. As Olga Rodriguez, she's been a member of this group before or has attended meetings before, but she just got pulled into another meeting. Sue Shell, welcome. It's great to have you here. You want to introduce yourself to the group?
Sure. I'm Vice President Clinical Director for Behavioral Health at Children's in Dallas. So I've worked with Dr. Trivedi and Dr. Ibrahim and Tamiga and many others involved in this work. And I appreciate being included.
Very good. We appreciate you being willing to serve, and it's great to have you here. And Dr. Nathan Maxwell, you've attended here, I think, one or two other meetings recently. And again, it's great to have you here. We added Nathan, Dr. Maxwell to represent the educational service centers. And so again, thank you for being here. With that, the number of individuals we need for a quorum has gone up just a little bit, and we'll continue to follow that closely. For the new members that are here, a couple of kind of ground rules of how we run these meetings. We have to obey the Open Meetings Act. And so a couple things that we need to do during these meetings. One, if you could turn your cameras on for the executive committee members and leave it on as much as possible, that'd be greatly appreciated. If you have to leave, if you would let me know, because again, I have to follow the quorum and make sure that we are at quorum throughout the meeting. And also, we can't really use the chat box. And if something gets put in the chat box, I'll have to read it out loud because that's just how the open meetings work. And being able to use this technology and allow individuals to stay at home versus coming here, we have to follow a couple of these technical rules. David, did I leave anything else out?
That was excellent.
Yeah.
So, Dr. Lakey, this is Danette, and I just wanted to let you know that while it doesn't impact your quorum issue, I am here in case there are any questions in place of Lee, kind of at the last moment, because he did get pulled away.
Okay, very good. Thank you, Danette. It's always great to have you here. And again, please feel free to chime in. Always value your insight and your wisdom as we're putting these projects together. So thank you. So with that, are there any other announcements before we get started? Okay. Hearing none, the first item, we need to approve the executive committee minutes from August 21st. Take a look at it. I'll need a motion and a second, and then we can move forward.
Move to approve Potter Wills.
Very good. Second from Ibrahim. Any further discussion? Hearing none, all in favor of approving the minutes signify by saying aye.
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 Opposed, nay. Did anybody abstain? They are approved. All right, we are going to now go into updates from the various groups and different projects. We'll start off with the communications update. Melanie Susswine, I saw you just a little bit ago. You want to give us an update on the work of on communications?
Yeah. Hi, everybody. Good morning. Thank you. I'm providing a verbal update today and not a PowerPoint. So our team, CHC at UT Austin, we're working on TChat, PeriPan, and CPAN. So we're doing a couple, I'll start with kind of the larger things that we're working on right now. One of them is the branding guidelines and a review since PeriPan is now statewide. We're working on how to bring that brand into the CPAN brand since it's an extension of that program. And we should have some updates on that by early next month in terms of how to keep the programs distinct in perhaps a color scheme and keep them as a combined initiative. So we're working on that. We are also for the PeriPan and CPAN programs, we're working with the coordinators and with the medical directors on a combined kind of editorial calendar so that we're promoting and working on the same things across platforms. So we start with an event for the month. So for example, I'll run you through Thanksgiving. So it's a month of thanks. So we've started doing that with the social media, with the PeriPan video that we'll be sharing, and with the TPS newsletter, focusing on that. The PeriPan, the TPS newsletter is something new for CHC that will be helping with that content. And our first newsletter will be in November, and we're working to tell the story of how PeriPan can be used by a pediatrician as we try to continue to bring these two programs together. For PeriPan, we're excited that the website page for PeriPan is updated and complete. We're working to integrate an SEO report to continue with that. In addition, on that PeriPan page, you will see that the video that we created is complete. So on the PeriPan website page, which you can look at texasperipan.org, you will see the full almost 3.5 minute video that explains the program. From there, we took about 5 what we call cutouts that are small, 15 to 30 second ones. We use those in our digital outreach, and we're getting excellent response to our doctor cutouts, and see the impact, as we know from our messaging that a doctor might create a new behavior based on what another doctor said. So we're really trying to use that, and you can see that in the videos. We're also working across platforms, and every month for the next few months, we will be releasing a new one of the cutout videos. And we're working with the PeriPan coordinators for them to help put that in their own newsletter. So we're giving them content to be able to share for PeriPan and for CPAN. We're also working on TChat. We've just started working on TChat, and our first order of business, similar to what we did when we started with CPAN and PeriPan, is I'm working to set up meetings with all of the HRI, with the TChat leadership teams. Our goal is to review the materials and look for ways to optimize messaging and see if there's any messaging that's happening right now that we might be able to optimize either through brand recognition or through the actual text and wording. So we're excited to be able to work in that initiative as well, and thankful to continue to work on this important projects. So that's basically what we've been up to. I'm happy to answer any questions.
Very good. Thank you, Melanie. Any questions for Melanie? All right, I don't see any hands that are up right now. Lainey McCorkle, who does our work with communications here in UT system on these projects, couldn't be here today, but she'll have an update. All right. So one other rule I forgot for those that are in this room, please make sure you're on your computer, put it on mute and put the sound on 0. Otherwise we get that feedback. Any other questions? All right, hearing none, we will move forward. Luann, I think we have a couple new members that have joined us.
Yes, Dr. Librazon
Welcome.
and Dr. Olvera from San Antonio.
Okay.
Morning.
Good morning.
Good morning.
And Dr. Taminga.
Good morning.
Morning.
Very good. All right. Molly Lopez, I saw you just a little bit ago. How about an update from the work that you're doing on internal evaluation? And David Lynch, it's good to have you here in person.
Absolutely. So I'm going to jump in and then I'll pass it over to David. So I'm going to do mine a little quickly. So a few of the things that we are working on, of course, we are working to end out our last fiscal year and prepare all of our final metrics for fiscal year 23. We're also working to develop some dashboards for you all. One of the first dashboards we're putting together is one to summarize key metrics to provide some readily available data that's been cleaned, that's been vetted, that can be used in presentations. We get a fair number of requests for data that can be in presentations, and so we're going to try and make that pretty easily available to folks. And then we will begin working with you all to develop some programmatic dashboards for TChat that we hope will be helpful. So I'm going to show just a couple of TChat slides from that presentation dashboard. Yeah, so here is where we are as of August 2023 with campus enrollment in TChat. We have over 3.5 million students who now have access to TChat, and we have about 27% of schools that are still being engaged, who are represented as schools that our HRIs are actively working to engage and bring into the fold. We have 690 schools, sorry, that squished a little bit, and 5,546 active campuses. All right, next slide. Here is some of the TChat referrals as they're coming in, and I wanted to just kind of show, of course, those referrals are somewhat cyclical based on the school being in session. But we do have our August data in there that shows, if you want to make a comparison, 1310 referrals in August compared to 740 last school year at the same time period. So definitely seeing some continued significant growth. Next slide. Here are some of the sessions provided through TChat by month. If you see, we had 3,000 sessions in August. One of the things I wanted to show in this slide is just a note that we'll have some data up there that will help us look at total TChat sessions, et cetera, total encounters, total students served over the course of the program. And I wanted to just kind of highlight that we have passed 100,000 TChat sessions now, which seems like a nice point of celebration. All right, next slide. Here is a little bit about the number of encounters that are provided to students. You can see between 1 and 5 encounters, and we now have about 24% of students who are receiving more than 5 encounters. That's been a shift over time period as we've had some additional ARPA funds to provide some more extended services. Also a change that I wanted to note, and unfortunately it's not showing up very well here, but that very top line under proportion of students and families receiving different types of services and supports is actually assessment. And I wanted to kind of note that that has increased in the proportion. We now have many of our students receiving an assessment. Similarly, standardized measurement, so being able to understand the progress of a young person and use that within care with families and with young people has also increased in the proportion of students who are receiving that. Under supportive therapy is CBT. Sorry that didn't show up for some reason when presented. And supportive therapy and CBT have been high kind of throughout the course of TChat. Okay, last slide. We have about 56.1, well, we have 56.1 students or families who are referred after they end TChat care. The vast majority are referred to individual therapists, and you can see under there as well, child and adolescent psychiatrists, other therapy, and other referrals. So just wanted to give you kind of a little glimpse of what we're doing in TChat right now, and I'll pass it over to David.
Thanks, Molly. Good morning, all. Good to be with you. David Lynch from UT Austin, part of the internal evaluation team. I just wanted to give 3 quick verbal updates on some ongoing work from some of the different projects. Under CAP Fellowship and CPB residents, we've administered a request for information from each of the HRIs about the placement of those individuals to find out whether they stay in Texas, and if they do, what kind of settings they go into, inpatient, outpatient, payer mix, and things like that. And hopefully information has been summarized and is being reviewed internally, and hopefully share the summary results with you all at an upcoming meeting. But if anybody has questions about that, please feel free to reach out. Also on CPW, we've been continually administering a resident experience survey, and we've got same thing. We have some summary results on that are being reviewed internally now. This is just talking about their experience at their particular settings and their clinical experience. And so we have some high-level summary of that we hope to present at an upcoming meeting as well. And the last update is regarding PeriPan, a couple items on there, and maybe some of the other PeriPan folks will kind of flesh this out a little bit. But one, I've been working with the Texas Medical Board data to establish the clinical universe, which of potentially eligible clinicians to use the service. And this is super important so we can determine the use rate and the enrollment rates across the state and see what kind of effect we're having on that program. And we're also in the provisional stages of putting together a experience survey for those clinicians at the time of enrollment and at their first use, just like CPAN. We may do other surveys later on, but that's their first item of business. And for that, we've been drawing from the existing surveys we have for CPAN and pulling questions which are relevant, and then also finding out what other states have done in national organizations. So we've got a experience survey from North Carolina, and Lifeline for Moms is sending us some other information too. And then we'll be sending it around internally again for clinical review, and then hopefully I'll be launching that soon so we can start gathering that important feedback. So just a few quick updates on things. Again, if anybody has any questions about those, feel free to reach out. I think that's it. Thanks for the time.
Any questions? Well, Molly, I'm struck with again, the significant volume and growth from this year to last year, and that 27% is still the number of schools we are in the process of getting MOUs put in place in that pending category. But 73% of the schools right now, either through our service, we're probably about 65% of the schools through our service. But there are some that have other mental health providers they've hired or other TChat or other telemedicine services they've hired. But we're basically 73% of all the student population, all the schools in Texas now have mental health services through one of those approaches. Again, the volume of having about 100,000 encounters, that's a lot of work. And so again, thank you everyone for the continued diligence to build out the program. Any other questions, comments? No. Yeah, we had quite a few schools that came on during the summer in the last month, and there's still some others. And Lachelle will give us a little bit more detail a little bit later, and Laurel will give us some additional data. But again, I guess the other fact there that I think is impressive is that if you look at year-over-year growth, just looking at August, it's about double the amount of sessions from 1 year ago. So again, there's a lot of activity, a lot of kids that are getting the support through the work that you guys are doing. With that, let's transition to the external evaluation. Dr. Feskin, I saw you, and Dr. Savas, I think I saw you too.
Yep, and I'll go ahead and present this time. So we're in the process of analyzing the data we've collected from our surveys, as well as the trait data. And for this presentation, we're going to focus on our CPAN survey. So we can go to the next slide. This just gives you an overview of the flow of our survey outreach to all the HRIs, which was our goal. We surveyed 432 providers this year, and we're able to follow up with over 118 respondents. We actually got 124, but we are focusing the analysis of this survey on the users, and so I'll get to that. So our survey questions were really looking at factors influencing use of the program and satisfaction and implementation processes from the user perspective. The response rate varied from 13 or 14% to about 44% across the HRIs, with an overall response rate of 29%. And you can see here that we didn't exclude that many for reporting not calling CPAN. Again, that was part of that was intentional. So the sample identified a diverse set of providers, which we'll see some characteristics. And then we also were looking at how they responded by where their clinic location is, by the Clinic Opportunity Index, which is a geographic indices that you can look at a clinic area by this measure. So we were able to look at some equity factors in terms of where their clinics are placed and what populations they're likely seeing. So you go to the next slide. This is just some of the characteristics of the providers we included in the survey this year. So among those that we reached, we were able to survey, we have majority women. You can see 76% female, 57% were white. There's an underrepresentation of Blacks for the general population, but this may represent the physician population. And you can see the cross section for Hispanic and Asian. And then the years of working, you can see there we had two kind of peaks. One among 30% were from worked there as a provider for 5 to 9 years, and then there were 34% that were there for over 20 years. And these are, again, just the sample of people who responded to the survey that we reached out to. And then the provider role, you can see the majority were pediatricians, followed by nurse practitioners. And then the years worked were on average at that clinic were an average of 8.5. Majority reported about 36 hours a week. And then regular use was 36% of participants, and then on occasion use was 63% of physicians. And again, this is their responses, their self-reported response to how often they use the CPAN services. So you can go to the next slide. This is just, we have this survey, just to let you know, has over 57 questions. So we, for this presentation, we're picking just a few that we thought you would be interested in, but we'll have a lot more detail in our final report. Here you can see the provider reported reasons for calling CPAN. And the top reason here, you can see among the regular users was medication management, and the same was for on occasion users. So it's 12%, but it was actually this very, very close to referral assistance. The behavioral management was 6% for the regular users, 7%, 7.4 for the on occasion users. And then you can see that the rest of the categories were distributed among general resources, diagnoses, support, second opinions, advice for parents, assessments, crises, and school issues. So we can actually link some of these responses, the providers, to their trait use to validate some of what we're finding here, and also to explore these relationships by who served them on the consultation, and can look at this in more detail by linking to trait data. So we'll explore that as we go forward. So this next survey, this next slide just shows you some of the perceived outcomes for a few questions. So, when asked about how they benefited, 85% of the regular users said my knowledge in mental health care increased, and 76% of on occasion users agreed. They said then on a very smaller percent, less than 10% for regular users said slightly, their knowledge increased slightly, and you can see 21% of on occasion users said slightly, which makes sense. If they're only using it on occasion, they might not have benefited as much as those calling more regularly from their own perceived use. And then you can see very few said not at all. And then my skill to provide mental health care increased. Again, vast majority answered positively to moderately and very much. And then it's fairly similar by regular users and on occasion. And you can see the same kind of variation for slightly across regular and on occasion needs. And again, very few said not at all. And then in terms of their confidence to provide mental health care increased question, again, vast majority said very much or moderately. And then the slight use was the same kind of distribution, with fewer of the regular callers saying slightly and more 25% of the on occasion users saying slightly. So these are just a sample of the type of perceived outcomes and benefits that we have from our quantitative questions. We also had some open-ended questions, so we're analyzing that with a more qualitative approach, and you can just see one of the quotes from that where a CPAN provider said that they felt more confident treating my patients because I know that CPAN providers are available whenever I need them. And we have some really good testimonials from the qualitative portion of this survey. And then you can see recommendations and future use questions are included in this survey. And this is a sample of one where we asked, do you agree or strongly agree, neither agree nor disagree to the questions. I intend to continue using the CPAN program the next 6 months. Again, vast majority strongly agreed, And same with I would recommend the CPAM program to other providers, 98% strongly agreed. And another testimonial that we picked, and we'll have many more. And we do have suggestions too. So we didn't just ask for positive things. So there'll be suggestions. But here was one of the representative quotes that we pulled from a CPAM provider that answered in this field. I was pleasantly surprised at how easy it was to find such great mental health resources that could actually be used for our patients. No more jumping through hoops or guessing if the providers take their patients' insurance. So we thought that was a really insightful comment. So we welcome any questions. We know this is just a very short presentation. You know, we have 57 questions, so you'll see a lot more detail on our final report. But welcome any questions, clarifications.
Very good. Any questions, Dr. Samas?
Comments?
Sarah Martin, I see your hand.
Hi, I'm just impressed that they got 124 people to answer a 57-page questionnaire. That's amazing. We need to get help from you guys for our other projects.
Yeah.
But it's also great to know that, dang, pretty much everybody likes what we are helping them with, and that their confidence, so many people feel that their confidence is improved. It's just amazing. So it makes me feel good, because that's, most of the work I do for the El Paso hub is on CPAN. So it feels good.
Yeah, it should be really motivating to people delivering these services to read some of the qualitative quotes pulled.
Yeah, it's really positive.
Yeah.
So, good. And it's consistent with what I hear from TMA and other providers, that there's a lot of physicians right now that are very grateful for the work that you guys are doing, and the support from the legislature and the governor's office to roll this program out. All right.
Absolutely.
All right. Well, thank you again.
All right. Thanks.
We will now transition and talk about the research projects. And Dr. Nimroth, I will go to you first.
Share my slide. Are you on? Thank you all. This will be a brief presentation on behalf of myself and Dr. Newport. I guess the big bullet point to raise is that we've now recruited 2005 subjects into the Childhood Trauma Research Network. So an amazing accomplishment. You could see the data here, looking at the baseline visits. You change that top number, 2005, and then you see we have a remarkable amount of follow-up, much more than you normally see in longitudinal studies. And so we're starting to look at these data. I'm going to show you some of these data in more detail. The next slide. This is the hit parade of each of the HRIs and their contribution to baseline visits that I wanted to share with all of you. And, Austin and Southwestern have been neck and neck. And as you could see, Southwestern went ahead of us by one subject. So Dr. Stewart has been remarkable. And you can see the number of subjects over time by month with UT Southwestern, Austin, and Houston, and North Texas, followed by Galveston, San Antonio, the Valley, and then Baylor, Texas Tech, El Paso, Texas Tech, Lubbock, Texas A&M, and Tyler. So we're delighted by the cooperation that we've received from all of the HRIs. We're working with each of them, particularly those that have lagged a bit behind. Next slide. Remember that according to our protocol, we don't just do baseline visits, we follow longitudinally, which has been a much larger burden on each of the nodes. And you can see here again the number of total visits, which have been remarkable by the nodes. And if you look at the total, more than 6,000 individual assessments have been accomplished in this population. It really is truly remarkable. Next slide. If you see our retention, you can see it's pretty amazing that we are getting 2/3 of the subjects are seen for the 6-month follow-up, more than half for the year follow-up, almost half for the 18-month follow-up, 40% for 2 years, which is very good relative to other longitudinal studies. So this is going to be very unique data that certainly has never been generated before. Next slide. We have 3 publications, actually. The first 2 are shown at the top of the slide. One published in a very high impact journal, which was about our training plan for each of the raters and how we measured inter-rater reliability. And then Dr. Clark at A&M took the lead on looking at predictors of alcohol and substance use disorder. That's now been published. And then Dr. Axon at UT Austin just had this paper that's listed as submitted, accepted for publication in the Journal of Affective Disorders. We have 2 additional papers submitted, and then you can see this amazing list of publications that are in preparation. I want to highlight the breadth of the contribution from each of the HRIs. And so we have a publications committee that Dr. Wagner chairs. Dr. Lieberzon is on that committee. Dr. Suarez is on that committee, along with other members of the hub. And you can see we have a large number of publications that are going to be generated out of this amazing database. Next slide. So over 2,000 children enrolled, 3 manuscripts accepted, 2 more have been submitted, 8 others in development. We had a spin-off grant from NIH that's been awarded to Dell and UTMB, and we received a small grant from the Hogg Foundation as a spin-off, which helped us launch the trauma-focused CBT program. So thank you, Dr. Martinez. Welcome. Next slide. I can't help but resist showing you some data. This is the diagnoses of the children and adolescents at baseline in this almost 2,000 subject cohort. So 25% already fulfill criteria for post-traumatic stress disorder, about 18% for major depression. Interestingly, about 17% have no psychiatric diagnosis, even in the face of the trauma. And then you see these other diagnoses, relatively common are anxiety disorders, and of course, attention deficit disorder. We've been a little surprised by the relatively high rate of autism spectrum disorder in the population, and we're hoping that some of the research studies that will ensue will begin to look at that ignored population. Next slide. And then this is the self-identified worst trauma by the subjects admitted to the trauma network. And you can see most common are accidents of various kinds, car accidents, result of a natural disaster, for example. But you can also see a family friend ill or dying, and obviously probably largely influenced by COVID. But then you see the other unfortunate and expected forms of worse trauma, namely sexual abuse, then physical abuse as well, and then unexpected surgery, a burst appendix, for example, unexpected cardiac event, et cetera. And then you see all of these other forms of trauma, as you can see. And then we've classified them, you could see by the color codes, into violence and maltreatment versus accident, disaster, medical, family estrangement, et cetera. Next slide. So if you group the diagnoses according to their worst trauma, and then look at their diagnoses at baseline, it's quite revealing. So for those that have been exposed to abuse, sexual abuse, physical abuse, family violence, you see the very high rates of PTSD and the very high rates of major depression. If you look, and relatively few of those individuals have no diagnosis, right? If you drop down to look at, in contrast, having a family friend ill or dying, or having an accident, natural disaster, witnessing an accident, much higher rates of no diagnosis, much more in the way of anxiety disorder and depression, much less in the way of PTSD. So we'll be looking at these data, and we'll be obviously writing these data up, because there are obviously implications for treatment. I think that's my last slide. As an update, I will tell you that the trauma-focused CBT initiative is well off the ground. Dr. Newport may want to add to my comments about the progress we've made in terms of training psychotherapists at each of the HRIs to deliver trauma-focused CBT.
Yeah, thank you, Charlie. I can certainly speak to that. So the group had arranged to get the therapist at all 12 of the HRIs, up to 2 therapists at each HRI, formally trained and certified in trauma-focused CBT. Where we stand currently is 5 of the 12 HRIs already have a therapist who has completed one entire case and are ready to go, and several of them have actually completed the entire certification process. The remaining 7 should all be finished with at least one therapist having completed a case and ready to start seeing research cases within the next 6 to 8 weeks. So we're in good shape there in terms of having everyone ready to go. All right, any questions? All right, I don't see any hands, but continued progress. And so thank you, Charlie.
Thank you.
Oh, Dr. Dominga, did you have a question?
I do. I have a question about, I just want to have one comment, which is that the data are really very, very interesting. You guys have done a wonderful job. Do you find site differences in the kinds of trauma you're looking for, or in any aspect of the data?
We do, Carol, but I'll tell you what that I think primarily reflects is the different HRIs are recruiting at different types of clinical settings. So some HRIs primarily are recruiting from psychiatric settings, be it outpatient psychiatric clinics or inpatient psychiatric units, where others are disproportionately recruiting from emergency rooms, inpatient medical units, and so forth. And so that drives the traumas that we're seeing, I think, really more than anything else.
Got it. Thanks.
And just for those that are listening, again, we do have a firm wall between the clinical programs we have and the research programs, and continue to honor that. And so the research projects are using a variety of other methodologies to recruit people, which can vary from site to site. Absolutely.
That's correct. I think Madhukar has a question.
Madhukar?
So Charlie, this is exciting, and the trauma data, and we have the trauma data in our sample, and then you have the depression data, but more importantly, the chart data, the CHRT, which is a suicide rating instrument to assess suicide risk. And we have actually already published several things, and you have the data. So I think one of the other things that we you all, the leaders at this endeavor may want to think about is how we benefit from the combined effort. So and Charlie and I have talked about this, so I'm not throwing this new thing to Charlie, but that we need to look at trauma in our sample, but more importantly, across both samples, we need to be thinking about how to understand trauma and its effects, not only for long-term impact in terms of PTSD, etc., but depression and outcomes, but also suicide measurement and risk that we are actually doing across both networks. And I think it is, I'm biased because that's an instrument that we've developed, but I think that what we are finding is something that will become, in my humble opinion, the standard to how to measure risk. And that is a contribution of this whole network. So I think we got to think about how to to try to actually capitalize on that.
And Madhuga, I agree with you. And I think there are times we want to combine our data sets. For example, with the CHRT is one of them. The trauma measures are another, because then we're going to have 4,000 subjects.
Yeah.
And that'll be an amazing piece of data to analyze together.
With that, Dr. Trivedi, why don't we transition to your presentation, and then we can come back and have some further conversation.
And I will keep it short because I was told to, and there's a few slides. So how does it work? Monet, do you run the slides or do I? If you can show the next slide. This is the most useless slide. So we actually had to decide. I had a few minutes and I didn't want to go through all of it. So we have to figure out. So two things I'm going to highlight. We have the sample and we can talk about all the severity and all that issue, which we have done in the past. But two things we did. One is that we did a very elegant scientific symposium. I at least enjoyed it. And I'm going to ask my partner in crime, Dr. Wakefield, to comment on this. But I think that we had this 2-day symposium, that 2.5 day, which was fantastic. And we were lucky enough to have Luann actually traveled all the way from there to come visit with us, and that was fantastic. So thanks, Luann. But that was one, and the other is we in the process also trained interventionists for behavioral activation. And I'll come back to it, but the behavioral activation interventionist training is really the only workforce expansion project we have in this whole thing. And that is because these people are not already psychologists or psychiatrists, but they are actually interventionists who don't necessarily have to be licensed people. So we did that training, and we can talk about it. Next slide. And I know I'm under the gun for the time, but we had over 20 scientific posters and presentations from across all the 9 institutions. We had panel discussions with experts, and all of you were fantastic, but I have to still call out to my colleague, Dr. Cheryl McCallum Smith, who actually is our new entrant into this whole thing. And she was, thank you, Cheryl, for being there and your participation and your critique and all. We had 75 staff, coordinators, and PIs attend across all 12. We had hands-on workshop to develop manuscripts and proposals and generate grant funding requests. We had collaborative discussions on topics including behavioral activation, recruitment, safety planning, and more. And safety planning is an example, and I'll show you in a minute. We published on that. So now we have actually publications that are YDSRN, TCMHCC publications in the field already in place. Next slide. So the next component I'm going to talk about is publications. Next slide. This is our publication I was just talking about with Dr. Nemiroff, and that is this suicide risk assessment schedule rating is actually beginning to take off, and I'm getting a lot of inquiries nationally since this publication. The other was another rating instrument that we've developed that is actually helping us understand how irritability plays a role. And all of you know, unlike adults, in adolescents and young adults, irritability is actually a very important diagnostic criterion for depression, and we have a rating instrument that assesses it. And the third component is that no matter how we do all this, even if you have the best treatment in place, you gotta think about improving the way you deal with this with measurement-based care. So these are three major cardinal publications that actually bring YDSRN out in the picture. Next slide. The other one we just got published is this assessment of suicide risk and management of a protocol from this whole product. We did this in not only by DSRN, but as you know, Dr. Jenny Hughes and Betsy Kennard in our team trained and did this for even the CTRN, which is the beauty of this whole network. And Charlie calls me all the time, so at the risk of revealing, Charlie, what you do when you call me. But I think that this is unique, guys. Not anywhere in the country you have 12 all medical schools collaborating, and then two different approaches, two of different components collaborating so closely. So this is an example of that, and I think we should all you should all be proud. Thanks. Next slide. So the other one we published is the Baylor group with Eric. I didn't see him, but Eric, if he is on his team, Eric Storch and their team have been taking the lead on this idea of understanding obsessive compulsive disorder across this whole network in our network, and this is a publication. Next slide. And you will have access to all this, so you can look at it. This is the cardinal underlying paper that describes both the rationale design, baseline characteristics, and also the whole idea of a learning healthcare network. And in fact, when I visited Cheryl, and I'm hoping she'll comment on this, I think this idea of having this network and in all of the 12 medical schools is just the beginning, because we should be and can develop a learning healthcare network across all these 12 medical schools, and that will be a beacon across any place in the country. So this one, if you have any questions ever about YDSRN, you should see this paper, and it'll tell you what is happening. Next slide. This is about this is a little humbling and actually something we all should pay attention to. So of our sample of over 1,500 people, approximately 49% of them have had thoughts of suicide or attempted suicide. This is a serious illness we are dealing with in these medical schools where they see patients with depression. Any of our clinics that we are actually participating in, they are seeing the very severe population, and they are really more depressed, anxious, less resilient, have experienced more traumatic events, and more likely to use recreational drugs and participated in fewer social activities. So by the time any of our people in Texas, any of our youth end up in a child psychiatrist clinic, they have an illness that is significant, severe, and they have significant suicidal risk. So tells you this is, we are not dealing with just garden variety depression when we talk about the population we are studying. Next slide. We also have a publication that actually compared many different ways of measuring this, because measurement-based care, while important, everybody says, how do we do it? How do we ensure we can deliver it? How do we put it in place? So this is comparing several of these. Next slide. So as you saw, we have 8 publications that are already out, and we have another 11 under review, of which actually 8 of these 11 have now been resubmitted. And I'd be surprised if we didn't get all of 8 of them published. So therefore, we are close to 20 publications that are already out. and another large 20 others, 30 additional manuscripts, as you're seeing, are out there. So I think that, like STAR*D, in my humble opinion, YDSRN is now going to be a word. Next slide. So I'm going to stop here, Dr. Leakey, and see if there are any questions. I have to say I'm humbled. This is amazing. This is, and Charlie, thank you for your partnership on this.
All right, very good. Any questions? Yeah, Luann?
Hi, Dr. Trivedi, it's Luann. I just wondered if you might talk a little bit more about the interventionist training that you referenced and what that is and how it works.
So absolutely. We have a wonderful behavioral activation program. So just a little background on this. So when we got started with the district project, we were partnering with a number of primary care practices in town. We were using one of our softwares that now Dr. Wakefield and the Lubbock Health System is using, called Vital Signs 6. And one of the recommendations from that was for patients to be given behavioral activation. So therefore, that became a problem for primary care physicians because they don't have access to behavioral activation interventionists easily. So we then therefore developed actually an 8-session virtual behavioral activation program, which we have now published 8 papers on to show its effectiveness, which was purely virtual. And we worked with Sonia Demazian, who was with Neil Jacobson, the developer of behavioral activation. And so then what we now have done is taken that and modified it, updated it for teenagers. And one critical issue is we have now expanded the criterion so that it is interventionists who are not officially licensed clinicians. So we wanted to make it a pure workforce expansion project. And so therefore, these people are people who are interested in behavioral activation in children, but not really licensed people. And we have now a training manual, a training program. It's a 2-day training session. So before that, they do a lot of initial virtual training. Then they do a 2-day session. We certify them. And then there is ongoing oversight and certification, monitoring of their activity. But it's an 8-session virtual training program for behavioral activation. And for teenagers and young youth, that actually should ideally be the first line of treatment for depression rather than running to medications. So we did this training, and all the centers have actually identified people to be trained. And we did that first training session, and we'll have another one coming up soon. Yeah, and even before I go further, maybe Tara, you were there. Dr. Mitchell is like a master of all trades, so she's going to tell us. And Linnell, are you on? Maybe not, but so we have a wonderful, fantastic young clinical psychologist who's actually helped me lead this effort. And I wish I had asked her to send her my panel link, but nevertheless, she's online somewhere. But Tara, you know about the program, so.
Absolutely. It's a really, really remarkable program. It's we've got really great feedback from the first round of interventionists that got trained in it. Very approachable manual and handouts, all that are easily administered online through telehealth portals and platforms. And I think it's a wonderful opportunity and a unique thing to be able to train unlicensed providers to really be able to maximize the evidence-based interventions we're getting out there for youth and families. So I think this is a great opportunity. And you're right, we have another training coming up in just a few weeks at the end of October, beginning of November.
But before I end, I think Sarah, Dr. Wakefield, do you have any additional comments, mainly about the symposium? I'm always so thrilled, but let me know if you have any additional comments.
Yeah, thank you. That's what I wanted to circle back on, actually, because I think just showing that one slide and talking briefly about it doesn't do what we did there justice.
I was given only 5 slides.
I know. Well, I wanted to talk about, I wanted to give a shout out to Dr. Holly Slater too, and her amazing infrastructure building in that symposium. But not only did we sit together and think through with people, with individuals from multiple different backgrounds and clinical perspectives across all the different HRIs about where we could go and what questions we should be asking, but we really started to identify some gaps in care, and that's I want to focus on, because that's really the goal, in my opinion, in addition to building this research infrastructure, is so that we could understand what kind of care was being delivered across across the entire state and how that's working. And so we're starting to be able to tell that story with all of this data. And what that's leading to is identification and gaps, what's working, what's not. And I think will be instrumental in leading us to the next phase of implementation of services in our other programs, so that we can really understand how to get more kids better, because we can see that we're still lacking in our ability to do that. Access is important, but knowing how to measure this and how to improve care over time, I think the research networks are going to be instrumental in that for both trauma and depression. And just sitting there with all of these individuals talking about that was very inspiring. So we got a lot of feedback from different clinicians from across the state. Wow, this is, it really makes me feel like I'm a part of something that we're going to improve care for these youth. So it was quite a time. I look forward to what it looks like in the next iterations, and am thankful to be a part of it.
Thanks. And one more related issue that I think you all should know, like an example is, we are obviously conducting this research network and the larger project based on the parameters given to us. Therefore, we are not doing a number of things that a lot of researchers in the country would say, why don't you do it? And the good news with that is we are actually now beginning. So we already have an R01 from NIMH, which is 3.4 million, which is designed to study kids who have attempted suicide with 2 different interventions. Charlie and the network allows us to do something, and Charlie and I and the Baylor team with Sanjay Matthew and his team are submitting a UG1, UG3 grant as we speak. So it will be submitted this week, and thanks Charlie and Greg Ponzo and his team and Sanjay and their team at Baylor, where we are actually going to use EEG, which is an NIMH grant, will require a separate consent, guys. So you don't worry, we will ask for a separate consent. But that will actually allow us to use EEG to determine whether you should take this medication, that treatment, the other treatment. So I think it creates a platform that then can be used to argue for external funding that is not from state of Texas. So I think that is sort of both what Dr. Wakefield said about how this moves to the next stage, and then what Charlie may comment on it, but where we are trying to actually use the availability of this infrastructure to see as a ready-made platform for new studies. And I visited Dr. McCullum Smith, and maybe she can comment, where we are already talking about what we can do together as a next step. So before I start with Cheryl, maybe Charlie, just make sure we're on the right track.
Yeah, thank you. And I think it's a tremendous opportunity for implementation science, which I know from talking to Madhukar over the years and Israel and others, we know all these programs work, but how do we demonstrate it in real world settings and demonstrate how to implement it? And so I think that's really exciting, but also really an opportunity for us to grow our faculty at the other medical schools and to show the strengths of each medical school in working in cooperation. I just think it's tremendous. So yeah, thanks.
I have a question from Charlie, or comment?
No, just a comment. I just want to be clear that Maduka and I have been assiduous in following the guidelines from the state legislature and from this body as to the type of research that we conduct under the guise of the Texas Child Mental Health Consortium. And that we are respectful of those guidelines and will be following them. And the spin-off projects that we're talking about funded by NIH or foundations are totally distinct entities apart from the childhood trauma and depression networks.
Yeah. And that was part of the impetus of the guidelines when this initiative was put together, the whole consortium, with providing care, but also improve where we are related to research in mental health in the state of Texas. I was looking at some of the data today, Charlie, and the data from 2022 at NIMH. Texas as a whole got about 3.5% of the dollars from the National Institute of Mental Health. We have
And
about 9%.
that is
We have about-
exactly, Dr. Lakey, where we gotta change it. That's
Yeah,
what
that's-
Charlie is talking about. We are not trying to do any research on this network that was outside of our scope, but it provides an opportunity for us to get NIH funding that will improve from 3.5 to something more.
Yeah, and as I was saying, we're ranked about 8th in the nation related right now to mental health research. And
Yeah.
so this allows us to build some of the platform, and we will move forward. And we'll talk about our new investigator awards. But Israel, I know you wanted to say something too.
Well, just to complete the picture, TCMHCC has creates an infrastructure, conceptual, clinical, that allows people to develop and grow. Not all the activities that stem from TCMHCC are immediately reflected by direct reports. I'll just give you one example. We have another funded NIH project that was built up since the beginning of the Ukrainian war, where at least 4 HRIs out of 6 total are from Texas, from TCMHCC. It's led by Texas A&M, but it has representative from Dell Medical School in Austin. It has representative from UT Houston, a representative from San Antonio. And we have started D43 large project of training, both in clinical evidence-based care delivery in Ukraine, as well as building dissemination and implementation research there. And I just want to report that I returned last week from a week in Kiev. It was a wonderful opportunity to train about 50 providers who are hungry to learn about evidence-based care. And we talked to him about pharmacotherapy, the same concept that Maduka is also, it's PE, prolonged exposure for PTSD, TBT, transdiagnostic behavioral therapy that we did for people with comorbid substance abuse and PTSD. And we got enormous response to that, and we'll continue working for 5 years. So I'm very thankful to our group, but I want to say that it's difficult to see, but it's clearly based on the success of TCMHCC and the collaborative relationship that occurs and the support that we provide each other in the same goal of providing better care in Texas, in US and beyond, and specifically for trauma and depression as our groups specifically focused on. So thank you for that.
Very good. Again, that's the goals that we've worked together across our HRIs. All right.
Carol may talk about it. I mean, I think this is a very unique network. Carol's done this with schizophrenia, so she knows these are complicated networks.
Yep. So we're going to move forward now. Thank you, Dr. Trivedi, for the work that you're doing. Want to give you an update on the new and emerging child's mental health research initiatives. And again, a quick audible here. I need to readjust the schedule just a little bit. So we're going to have a quick update here. And then we're going to Joy Borges and Lisa Ramirez have to leave a little bit early. So item number 6, I'm going to bump up next. But want to let people know that we are working to put in the structure for the new and emerging investigators. We believe, again, as we develop research here in Texas, one of the key challenges is to get young investigators the support they need so they can be successful in bringing down federal funds in the future and address that 3.5% issue that we have. But Nagla, you want to walk us through some of the work that's taking place to get us in line to roll this initiative out?
Sure, yes. First of all, I just wanted to give a little bit of a background of the purpose of this is to really look at new and emerging child mental health research and it's designed to foster and encourage and mentor researchers and trainees and seek out maybe extramural funding focused on improving the mental health system in Texas. So there are 3 types of grants that we're looking at: the research career development, research project, and the postdoctoral fellow and trainees. And those were presented before, so I'm not going to go through them, but you could see here the 3 different types with a limit on the budgets associated with them. And again, all 3 are designed to really help new trainees and in their research and to help them also seek out additional extramural grants. So going through a little bit about the eligibility criteria, we are the folks that are eligible to apply have to be affiliated with one of our 12 HRIs. And what we're wanting to do is have any applicants get the support of the HRI. And we're looking at up to 6 applicants. That will give us about 72 maximum applications. Dr. Leahy?
And just to jump in here, and most of this are things that we've discussed before. But as we're looking at how do you really implement this, I think one of the challenges is just to not make this a free-for-all for anybody that works at one of the HRIs in the state of Texas, but continue to develop this in a way that supports the building of the departments of psychiatry, mental health research, et cetera. And so we will have ongoing conversations, but would like to help coordinate the activities from each of the HRIs through the chairs of psychiatry. That doesn't mean that people that work at other schools wouldn't be able to apply, but we want to make sure that the chairs of psychiatry are knowledgeable of that and supportive of that work, just to make sure that we have a process that's going to be logical and doable over the next several months. And so if there's any discussion, I'm happy to talk about that. But again, it's a way for us to keep it organized and making sure that the chairs of psychiatry are involved in this and supporting this work as we then go to the next steps of figuring out who we provide the funds to.
Yeah, I think it's a critical point. I'll just what you're raising up here, because as everybody knows, especially all the chairs, that getting the money is one thing, but getting the time freed and opportunity to get training, it's critical. And that depends on the chairs. So I think what you just mentioned is absolutely necessary component to make sure that TCMHC invests in a position that will have the chair support to become a future researcher. So,
okay, go ahead, Nagla.
Sure. And one of the points that was also presented in the past is that we're looking at the principal investigator can partner with other institutions that are not part of the 12 as needed. And that prioritization will be for those who have never had an NIH R01 grant. Again, this is an attempt to bring in additional researchers and provide them the training they need in addition to providing this support to this grants. Trainees include clinical and research fellows, and principal investigator has to dedicate at least 25% of their time with a maximum of 50%. And then proposals that are encouraged are those with diverse disciplines. Just wanted to show you a tentative timeline for the submission process. So we're looking at opening up the RFAs in January of this following year. We want to start off the application process with a letter of intent. So we have an idea of the number of applicants and have an idea of and provide them with whether they are eligible ahead of their application process. We would like to complete the grant application process by August 1st with the initiation of the grant. And so again, this is a tentative timeline. We're working through it and wanted to go through the activities we've done so far. We've identified a list of potential reviewers, thanks to everybody who submitted their recommendations for reviewers. We've also received suggestions and scope of research and evaluation by HHSC. Again, thankful for HHSC for providing both the scope of potential evaluation, but also resources that will help the applicants in determining the research. Go ahead, Dr. Lee.
Yeah, and we wanted to make sure that we were aligned with HHSC on this. And so this was important to us to make sure that the research that we do is supporting HHSC and what they see are fundamental challenges with the mental health system here in the state of Texas. We think that's a good use of state dollars and figure out how do we improve the mental health system. And they have given us some, I think, some very good topics that are written broad enough that a lot of researchers can get in, but again, are focused enough that they're going to be of use to HHSC in their work to improve the system here in Texas.
And then we also met with CPRIT to understand their processes and to identify some of the documents that would be helpful. This is very similar to a CPRIT process. And so they've been tremendous in their help and support. We've identified 2 potential grant software. So we would like to use a system that's more innovative. And so Lachelle has been great at kind of identifying what are the best systems that we can utilize to make this efficient and useful. And then we've initiated a document that includes what the review process needs to look like, the reviewer expectations, applicant eligibility, and the process, and then how we would monitor those research after folks have applied and received those grants.
Is it a moment for comments?
Sure, go ahead. Yes.
I would strongly encourage people to revise the minimum time requirement. Saying frankly, I trained more than 20 or 30 researchers to the full extent, and I cannot believe that somebody with 1 day and a quarter a week is sufficient for them to develop research career over 2 years of the grant. So my suggestion is that has to be increased to the minimum of 40%, which means 2 full days, if not more. Otherwise, we are setting people up for insufficient time to really develop their scientific abilities.
Now I have a question related to the 6 applications. Are those 6 applications from each HRI going to be designated to be 2 from each of the categories, or
No.
is it simply 6 regardless of
6
category?
total regardless.
Okay.
And so we're not setting a requirement on how many for each category. We're just looking at any of those categories and hoping to get at least 1 out of each in total.
Okay, thank you.
Sure. So next steps that we're working through before I take Dr. Trivedi's question is we're outreaching to potential reviewers. We're going to be purchasing and setting up the grant software. We're identifying payment methods for the term of the research. So we will be crossing the biennium, and that's the reason why we're looking at what is the best way to handle that. We're finalizing instructions to the applicants, including the templates for submission And we're going to be scheduling Q&A sessions for the applicants and orientation for the reviewers. And then as mentioned, we're hoping to post the notice of funding opportunity by 1st of January or soon after. And so we'll be working towards how to schedule that and make sure that we can implement that. And these are all the slides I had. Let's see. I see first, Dr. Trivedi, you had a question?
Two questions. One is, does somebody applying have to be a faculty, or can they be seniors, like research scientists?
Oh, actually, yeah, they can be, we're looking for research scientists or folks who are postdocs or, post-clinical researcher.
PhDs
So-
or MDs, yeah, okay.
Yeah. So it depends on the grant type, you will see. So there's a variety of applicants, and we're looking for those who may not have had an R01 in their past and as a priority, so that we can make sure that we link them with the right training.
And have you defined, that's the second question, have you defined the domains of work that you are willing to fund, or is it up to the proposer? Like,
Right.
Is a basic scientist can apply, or clinical scientist, implementation scientist? What kind of work is allowed under this?
And Dr. Lakey, I think, is going to take that question.
So sorry, I got one of those calls that I had to take, and so I stepped out, and so I missed maybe just a little bit of that. But so Madhukar, can you give me the short question again?
Is the domain of work determined already or described? Like, can you be a basic scientist? Can you do implementation science, population health? What part of the domain is this initiative willing or able to help?
So we said that we would align with HHSC related to what they thought were important. It will be more on the health system research side than in the basic side. I think we're still constrained by the other things that Gardner or other or guidance for our other projects. But we told the legislature we would focus on how do we improve the systems of care here in the state of Texas, and we'll again align with what HHSC has said are the priorities for us in Texas. Okay. Now they're written a little bit broad, and so there may be some opportunities there to think a little bit differently. But again, we want to be aligned with the same messages we've given the legislature over the last several years about how their dollars invested in this research are going to be used to improve care here in Texas. Okay. Let me go to Steve Pliska, and then Jeffrey, I'll go to you. Steve? Steve, you're on mute, my friend.
Here I go. Sorry. Let me get my hand down now. The question on must have the support of their HRI. Well, obviously, you want to support them by your helping them, telling them to go ahead and apply. But is there going to be are going to be a specific match or additional time beyond what the grant's funded that needs to be supported? How will that be defined, or is that?
So what we were looking at there was to make sure that we coordinate through the chairs of psychiatry that they are in agreement that this is one of the top 6 from their institution that they want to move forward. Okay.
All right, great.
And that puts the chairs in a position to be able to know what's going on in their university as they apply. Okay. Cheryl?
Hi, I think some of it's piggybacking on what some others have said, and I appreciate Dr. Lieberson, Israel, what you're saying about, really developing a really hardcore research career. But I think for implementation science and for some of the folks who don't have, an MD, PhD, or a stronger research background in this is a great opportunity for us to develop faculty at in doing implementation work. And I think that people need good mentorship to succeed at 25% time. But I think, I don't know if we want to distinguish between types of work being done. But I think for training implementation folks, that 25% could be enough.
If I may comment, Cheryl, I mean, I have wonderful colleagues in implementation science that would kill me if I tell them that 40% is enough. The real implementation scientists, people who spend their career in this area. So I do not want to, in my mind, I would not be suggesting that some science requires less rigor or less time to invest than other. I think it really depends on more an individual and their training plan. But my point is that especially at the beginning, you were talking about junior investigators who have not really spent time significantly on research. If we don't protect 2 days a week for them, they will be swollen by their clinical responsibilities. And I've seen too many people failing in this process. That's why I said that 40%,
right.
My mind, it's a minimum. So if somebody wants to take a risk, they will also have to take a risk if this person, after 2 years of training, fizzles. And I don't want to take that.
You know, I mean, I may be one of the people that you might consider have fizzled, but I think that I agree if you're going to be doing research and getting NIH grants, but I think for the smaller systems here, that may not be our goal with doing research, is to have people that eventually I'd like to build that, but for me to get started with people and get some projects going, I need something that's not as NIH or NIMH grants, more like looking for foundation grants and other things. So there just may be different goals. I'm concerned that making it 40% would make it inaccessible to some of the smaller sites. That's my concern.
Let me intercede here for a minute and just say that these funds will be somewhat fungible. And we recognize that different systems have different needs. And so the folks that are going to have the Career Development Award, that will be more of a traditional Career Development Award, which would provide the kind of protected time that Israel is talking about. The project grants are a little different. And you may have somebody that's 20% on a project grant, another person that may be 10%. So I don't think we need to get in the weeds today and have this philosophical discussion about the percent of protected time. But I think it's an iterative process. And as the applications come in and the committee provides feedback, we'll be able to sort of see where this goes.
Jeffrey?
Yeah, thank you. I wanted to point out something with regard to the first grant type, the research career development, which, clearly from the name is patterned after the NIH Career Development Awards. And those, there's 3 components of the funding. One is the salary support for the awardee, but the others are support for the project. But then the third part is support for the training plan. But included within that is it's spelled out for applicants in advance that the way that those applications are reviewed is, yes, the quality of the project they're proposing is reviewed, but also the quality of the training plan.
And that'll be part of this.
Yeah, and I think in the RFA, we need to spell that out.
And a mentor, and we put in that we could put in some funds for the mentor.
Right.
To make sure that they have dedicated time.
Okay. All right. Thank you.
And I guess the one thing I would say, and again, I had to jump out for a little bit of this, is that we're trying to do due diligence. I think that's why we had the conversation with CIPRA, to make sure we learn from their lessons of how do you manage something like this. This will be the first year, and I expect that we're going to learn some lessons, and everything isn't going to be perfect, but it'll be very good. And it'll get a lot of individuals an opportunity to make a next step in their career. And then we will learn from that and continue to improve and build upon this initiative.
Yeah, I just want to say that my comment had to do with, especially with career development, the first line of those 3 projects, and not the smaller or isolated grants. So I specifically spoke about career development awards.
Octavio?
Just to comment, I mean, I think this is a great development for the consortium. However, I do want to encourage and ensure that the review process is inclusive and ensuring that we're lifting up researchers also that are very diverse. I think it makes a huge implication, I think, not only for our clinicians and providers, but that our researchers really represent the whole breadth of what represents the state of Texas. Just want to make sure for when it comes to the selection process,
Yeah,
that, you know, those biases and sort of blinders we have sometimes are at least thought about to include really having researchers that I think will really lift up the consortium.
all right, very good. Dr. Trivedi?
One tricky question, that's why you have the big title, is how do you see senior investigators involved with this? Can Charlie apply?
No.
Charlie, I'm not picking on you.
Charlie
So
cannot.
how does it work?
Dr. Trivedi will not be able to be an applicant. None of the people that are in this.
I'm lower than Charlie.
Where you will be involved, though, is to be able to find good upcoming individuals that they're going to be invested in and that you can mentor. And that will be your involvement. But this is focused on new and emerging researchers.
So on a serious note, I think it may be worthwhile kind of clarifying how you want senior investigators to. I understood what
Next car was signed.
I understood what you were trying to do. I was just trying to say maybe some language around it may help.
Yep. All right. So we will, in that application process, make sure that these issues are addressed. And again, we'll be transparent with this group. We'll be transparent with everyone related to how we're moving it forward. We did put in that, you know, the reviewers aren't the final decision makers. This group will be involved in the final decision and approval of who will get funding. Okay. All right. Any other questions? Hearing none, I'm going to transition because I know their time is limited to Joy Borges and Lisa Ramirez to talk about the success that they recently had in related to getting extramural funds and a project that can involve the work of the consortium. So Joy and Lisa, let me hand it over to you.
Thank you, Dr. Lakey, and thank you for accommodating my schedule. For those I haven't met, I'm Joy Borges. I'm the Associate Commissioner for Family Health Strategy at the Health and Human Services Commission. So I lead a variety of efforts related to policy, technical assistance, consultation, communication, strategic initiatives to improve the well-being of women, children, and families. And I'm joined by Lisa Ramirez on our team. Lisa, I think you're on. But anyway, we are very excited to be here today to talk about some new funding that came through. I'm sure this group is really familiar with the impact of maternal mental health issues. Notably, mental health and substance use conditions are a leading cause of pregnancy-related death. Drug overdose specifically has been a leading cause of maternal death. And we know the impact that maternal behavioral health needs can have not only on the mom, but also the child's development, making investments in this area important, not only for our current state, but our future state as well. So there are a ton of initiatives going on at both the state and federal levels to address this, including Period Plan, which I'm so pleased to hear a lot of the work going on right now. So in April, HRSA released a notice of funding opportunity for a screening and treatment for maternal depression and related behavioral disorders program. So this funding was authorized under you may have heard of the Into the Light Act for Maternal Mental Health and Substance Use Disorders in 2022. It authorized funding from 2023 through 2028. And this was a second act that passed. The first one did fund a bunch of different Peripan type programs in different states, but this was the first one we actually applied for Texas. The opportunity was limited to state entities, so HHSC offered to apply for it on behalf of a collaborative effort with PeriPan, UT Health in San Antonio, their Be Well Texas clinic. And then we also worked closely with our partners at the Department of State Health Services because of their leadership on maternal morbidity and mortality reduction. So I'm pleased to say that last month we received notice our proposal had been selected, one of 12 selected for funding. So our implementation meeting, our kickoff is actually scheduled for Wednesday, and our first performance report will be due in January. So it's a busy time, but we should have more to report in future consortium meetings as y'all would desire. So I'll talk a little bit about the proposal, and Lisa's here, A, in case I have to take off, and B, because of her work, she can help me answer any kinds of questions y'all may have. So we know that the legislature had already funded statewide implementation of PeriPan, very exciting. So when this funding opportunity came out, it wasn't so much about expanding PeriPan even further geographically, but we wanted to look at how we could enhance that network and really complement that program. So one of the opportunities we identified was looking at the screening and treatment of pregnant and postpartum women with a substance use disorder. We hear anecdotally that is a gap, and the evidence suggests that there remains a disconnect between providers' understanding and ability to screen and refer for mental health and substance use. So to address this, we developed a proposal that focuses on workforce training and capacity building and community-based referrals. Again, leveraging the existing PeriPan network and then the current efforts of Be Well Texas. And if you're not familiar with Be Well Texas, it's an organization associated with the UT Health San Antonio. It works with a network of providers across the state to offer office-based opioid and medication-assisted treatment. And they also work with a network of peer services or recovery support service organizations with a specific focus on isolated and rural counties. And together, the peer networks and the treatment network served more than 13,000 people during fiscal year 2022. So we see Be Well Texas is a hub for training and technical assistance to enable network members to obtain necessary training to offer substance use treatment. Very similar to PeriPan, it really works to increase provider capacity at the local level and provide just that consultation, technical assistance. So ideally, people can receive services closer to home. Be Well Texas, though, will also provide both in-person and virtual care with people across the state. So we're hoping by partnering Be Well Texas with PeriPan, we will help sustain Be Well Texas' ability to provide direct services, and then also complement the work of PeriPan to expand the network of consultations and availability of maternal behavioral health specialists to support those local providers. So ultimately, we're thinking this partnership will expand our ability as a state to detect maternal mental health and substance use disorders, and then provide that access, hopefully to improve maternal health outcomes. That's the end result. So there are 3 goals we've laid out in the proposal. First being to build that capacity of Texas perinatal workforce to offer routine screening to women. So this is through that building knowledge and expertise and helping provide consultation. We want to make, by the end of the grant period, we hope that 200 additional perinatal providers will have the capacity to deliver screening and connect women to treatment and recovery support. Our second goal is to increase that real-time psych consultation and consultation for substance use screening, treatment, and recovery resources. For Be Well Texas specifically, we're hoping that they, by the end of the grant period, will be supporting an additional 150 providers. And then ultimately, we're seeking to serve an additional 500 women with screening, referral, and treatment specifically for perinatal substance use. And then our third goal is to increase access to treatment and recovery support services for those women. So this includes expanding the network of providers under the Be Well Texas network, so that they have presence in all 254 counties. And then we're seeking that 100% of underserved women will be connected to in-person or telehealth treatment, ideally with a 95% satisfaction rate. So there's 4 different kind of methods for this, and I apologize, I don't have a PowerPoint, but we would be happy to provide any of this in writing as well. Our first deliverable will be improving outreach training and telementoring to perinatal providers. So really leveraging the ECHO platform. We know that this works, and the Be Well Texas Center, they already have a suite of substance use focused ECHO programs. And so with the money offered in this grant, we are actually looking to have to develop an ECHO training and technical assistance specific to maternal mental health and substance use disorders. Second, again, making available that real-time psychiatric consultation. So that's the other thing we'll do, is really making sure that Be Well Texas is supporting PeriPan, complementing that network to make sure that perinatal providers, whenever they need assistance with either mental health and or substance use, that there's somebody there who can help with assistance with diagnosis or medication management, connecting them to recovery support services. The third deliverable will be increasing that network for direct services through either Be Well Texas, their clinic, or the providers that they work with. And then the fourth deliverable we have is creating a directory of resources for the referral of pregnant and postpartum women. Again, leveraging some of the existing materials that exist both through PeriPan, HHSC, and Be Well Texas, but really creating some sort of digital dashboard that would make it very user-friendly for someone to go identify what services are available across the state. So it's a 5-year grant. They've committed 1 year's worth of funding. If we show success, we would be eligible to receive $750,000 every year for the full 5 years. We do have a $75,000 matching requirement, so full funding towards this effort would be $825,000 a year. I'm so thankful for the work that some of the folks on this call did to help us apply for that grant, and especially to Lisa, who's joining me today. She is listed as the program director and principal investigator for this grant and will be the best contact moving forward. She has spent, many of you know her, she has spent a lot of time in the maternal child health and substance use spaces. So she really is to thank for getting this project, even the application together. So with that, Lisa and I can take any questions, or Lisa, I'm sure I left out something really crucial, so please feel free to weigh in.
No, you did a great job. I would mention that we had our first meeting with HRSA and the other grantees, and I was really pleased to see that that what we had put together in terms of a plan and collaboration with experts in the state was really in alignment with some of the work that previous grantees noticed and identified as gaps. So I think we're on the right path, and I think there's a lot to learn from other states as they're embarking on this journey as well. So I'm really looking forward to this collaborative effort.
Can we get a contact information from you guys? Because we have faculty now, HRIs, that actually have projects that right in line with what you're doing. So it would be good to put it, make a contact, and maybe you can use their resources and vice versa.
Absolutely. Luann, if I send Luann our contact information, can you get it out to the consortium?
But how about if you send it to Luann, and then we'll send it out to everybody.
Sounds great. I'll do that.
Very good. Sarah Martin, I see your hand.
Yes, I was just wondering if Be Well Texas and then this new program is going to be open to people that are under 18, or is it just adults?
I think, well, I think that Be Well already is able to accommodate capacity for under 18 as well. I know they're focused on emerging adult populations and other programs and projects that they're working on. I don't think that should be a problem. And we did not identify that as a limitation. I'm not aware of that as a limitation of the grant funds, but I could double check to see.
That's great. That's great. Thank you.
Very good. Any other questions? All right. Hearing none, again, congratulations, Joy and Lisa, for successfully, securing that project and the work to help coordinate the different activities across Texas. And it sounds like there's a tremendous opportunity. So again, we look forward to working with you.
Same. Thank you.
Very good. So I have been notified that lunch is here. And so we're going to take a break now and then we'll finish the agenda. I don't think that the rest of the agenda is going to take that long. But why don't we go ahead and take a break? Let's go till 12:30. We'll go to 12:30. And before I do that, I guess I want the record to show that we had a couple people that joined us. Dr. Chapa joined us and Dr. Jair Suarez joined us. And yep, very good. So let's just make sure we have them down. And again, at 12:30, I'm going to again have to take attendance to make sure I'm at quorum. But again, so I would ask that everyone be here very promptly at 12:30 so we can get going.
And one other request, if everyone can turn off your microphones, that would be wonderful. Thank you.
My iPhone tells me it is 12:30. I hope everyone had a chance to take a break. Again, I would ask all the executive committee members to turn on your camera so we know that you are there. And we'll go ahead and take roll again.
Okay, Babatope. Here. Chapa. Farmer.
Here.
Gaines. Goodman.
Here.
Ibrahim.
Here.
Ida.
Present.
Johnson. Keller isn't here. Lakey.
Here.
Liberzon.
Here.
Martin.
Here.
Martinez. Maxwell.
Here.
Mayor. McCullum Smith.
Here.
Mitchell.
Here.
Nemiroff.
Here.
Newport.
Here.
Nichols. Olvera.
Here.
Kliska.
Here.
Podewelts. Rodriguez. Schlacklin. Shell.
Here.
Scott.
Here.
Flores.
Here.
Kaminga.
Here.
Thompson,
Here.
Vo,
Here.
Wagner. I thought I saw Karen Wagner. Maybe not. Oh yeah, there she
I'm
is.
here.
Okay. Wakefield. Williams.
Here.
Okay.
Right, Luann, Chop is
Oh.
here.
Aye. Okay. You've got 20.
All right, we have 25 executive committee members here, so we are at quorum. So we'll go ahead and begin. According to my notes, we're now at 3E. And so Dr. Plitzka, thank you for being here. Dr. Plitzka is going to give us an update on our data management and governance committee work. Go ahead, Steve.
Well, thanks. So I don't have a PowerPoint. I was kind of lay out the issue for the executive committee and kind of we can have some discussion. So you may recall at prior meetings, we discussed the issue of the role of the data committee, its membership, and how it could best carry out its task. And so I've had some time to talk with members of the committee, with Alex Vo, the co-chair. We also looked at some of the issues that have come up, and I'm posing to the executive committee the possible need for a change in the structure of the data committee, as well as perhaps the policies around it. And so let me elaborate a little bit. So we get we get regular reports here that have a lot of data in them, you know, that those largely focused on the service aspect of the programs of the consortium. So whether it's CPAN or TCHAT, you know, we're looking at the number of providers we've reached, the number of sessions we've done, the number of school districts, you know, and that's all, as you can all see, that's going quite well. The data committee has largely been charged with the issue of the data that we gather with respect to the demography of all the clients, their diagnoses, any clinical change, you know, what's the validity of that data? What of that data will we analyze and release to the public? And when people want to do publications, obviously they need to submit to the data committee to seek permission. And the data committee reviews publications, makes comments, either approves or disapproves. I think when we constructed the data committee, each HRI has had one representative, and by and large, the people on the data committee are not researchers or not data people as their day-to-day work. Now, there's certainly many who are knowledgeable of clinical research, but that has led to sometimes the overlap of the data committee. Instead of talking about data issues, we end up kind of maybe talking about some other clinical operations issues or how data management will impact clinical issues, and that's not always useful. More significantly, I think we want to move beyond sort of just looking at what our service reach is and start to ask some questions about the clinical outcomes, you know, of people in CPAN or TCHAT. Now, I want to reiterate, as we have many times here, TCHAT and CPAN are not research projects. We're not randomizing people. We're not putting them into any type of research design, but we are following people clinically, and we're attempting wherever possible to do measurement-based care. And out of that, at least it was the anticipation that the data committee would oversee some degree of project evaluation in conjunction with the internal and external evaluation teams. And I'm going to invite some of the people on those teams and others on the data committee or in COSH to comment. So yeah, you're not just getting my particular view of it. But I think the problem that we've begun to find is that we're using TRAIT as our sort of data gathering tool. And TRAIT wasn't necessarily envisioned in the way it evolved for doing that. So TRAIT was developed initially to be the framework for CPAN, for people to document their calls and for us to track the calls. And then it kind of got, as I understand it, kind of drafted into working with TCHAT. And again, I think its role has slowly evolved from, we'll just keep track of how many districts there are and how many patients people are seeing, to this larger issue. We're collecting measurement-based care, and then we try to do analyses of that data. But the data committee was never kind of necessarily involved in the design, or not directly involved, shall I say, in the design of the data gathering method. Or if we were involved, it was a little bit more on the peripheral side or sort of after the fact. And I think what has begun to occur is the data that's in trait, well, it's very good for tracking, for what it's doing, CPAN, tracking the calls, doing the calls. Clearly, as you saw in the presentations today, it's helping us look at the reach that, the clinical reach that we're getting in terms of serving kids. But if we want to ask some more advanced questions, like what are the diagnoses of people being served by TCHAT or CPAN? What are the outcomes? And the executive committee voted a number of sessions back that we did want to begin to assess outcome in TCHAT, in particular, some more systematic ways. We're discovering that the data coming out of trait, through no fault of trait or anybody involved in constructing it, just the way the process has evolved, is not always the kind of data that would be reliable enough that we could publish it, rely on it. To give just one example, the diagnoses in trait, people can choose from a drop down of DSM diagnoses, but there's also an other category where people can free text type in a diagnosis. And as you might imagine, what has occurred is people have a great deal of data, people doing data entry at the individual HRIs. We're choosing that option. And so we've got a whole potpourri of non-DSM statements, sometimes diagnosis spelled multiple different times, because human beings, when they type things into a text box, are going to misspell things. So when the internal evaluation team goes to look at that, they find that it's going to take an extensive amount of data cleaning to get that in any sort of shape that we could present it publicly. And even if we do that amount of data cleaning, that introduces potentials for bias and inaccuracies that might lead us to say that the data is not that reliable. And the data committee was not aware that was going on. I think if the data committee and people on the data committee with more data expertise were aware, we might have kind of put advice in earlier, say, hey, you don't want to do that because we really want to know what the specific diagnoses are. Now, granted, there's a whole series of reasons you could argue, well, no, people do want to have a free text box, or there's multiple different ways to do it. My point is that I knew the right way to do it. I'm not saying that at all. What I'm saying is that if this had been looked at from a data perspective from the beginning, we might have anticipated that difficulty and saved us a great deal of work. So the data committee itself is so large, it's a somewhat cumbersome group, to make sure everybody gets all their input. Again, people come at it from a clinical perspective rather than a data perspective. And so the data committee really isn't the forum for it to be involved in how do you set up COSH, or how do you set up trait? Maybe trait should do it this way rather than that way. And I think we're on the horns of a dilemma here that I think we need to resolve. I have some ideas about how to do it, but I wanted to first kind of set out the issue. And maybe Alex is my co-chair on the management committee. I think, Alex, do you want to add something to that?
Yeah, I agree with everything that Steve had outlined. I just want to make clear that when the data committee reviews these manuscripts for publication, it's not to review the scientific merit of it as if we're an editorial board. It's more to actually review whether the data that they're reporting is actually accurate, that's in the databases that we have. So it's a data integrity review more than anything. So I just want to make that one comment so that people are not confusing the fact that, we may be reviewing it from a journal perspective, which is what add that. But in essence, I do agree with Steve's concerns and outlines, and we do probably need to revisit this and outline a new structure.
So let me, well, first, thanks to Steve, thanks to Alex for your work on this committee. We have some time for questions. Again, I would ask people to again refrain from using the chat box because this is an open meeting. And so I'm going to read the one comment that's in the chat box, and then would request that raise your hand and discuss. But Dr. Trivedi noted that overall, I would assume you want to know and be able to show that all that you are doing is making a difference in kids' lives, symptoms reductions, improvement in function, better performance in life, et cetera, et cetera. So Dr. Trivedi, I see your hand.
So sorry about that, and thank you for reading what I said. So Steve, wonderful, but I assume you're actually ultimately, there are two domains, right? Is how many kids or how many people you affected, but then whatever you did it make a difference? And I think that is where you're talking about. You got to have some way to document that. It doesn't have to be a randomized controlled trial. It is, if I do X, Y, and Z, who gets better, what, how much, etc. And you probably have metrics, or B, are doing it in research domains all the time, and maybe worth thinking about it, so that you can show that if you reach 10 people, how many got better in what way? That sort of, I think, is sort of sounds
exactly. And we've definitely made some stabs. I mean, like, we've implemented the Columbia Impairment Scale as a standardized measure that everybody's going to get, and that's now fairly clear. And I think that's going to be very reliable, and we can start to analyze that data as it starts to come in. But you're exactly right. We want to be able to know that what everybody's doing, what they're putting into trait, if as traits are sort of our data repository, is systematic, reliable, valid, and then we can put faith in our analyses when we begin to do them without having to do a lot of data cleaning and ad hoc kind of moving numbers around, so that we can at least can we make sense of them. So we
are going to be doing similar things with safety A, right? As like just because you do safety A with 10 people, what does it do with the kids is what we will have to measure.
Let me go to Dr. Williams next.
Thanks. I would say that in the conversation related to the Data Governance Committee, I think one of the things is I want to echo what Dr. Pliska is saying. We really wanted to talk about who should be on the committee. When it comes to the processes of data collection, again, for example, we looked at 40,000 records, 12 of them needed to be changed with something. So I think we also, when we talk about, we want to be careful that we're not sort of saying something that may be relatively modest issue is somehow a really large issue. But I think that what the concern is, that what I thought we were just going to discuss today was who should be on the Data Governance Committee, so that they can really help inform the process moving forward, how we can really make sure that the people that are on that committee have the necessary sort of background to sort of help, because the Data Governance Committee actually has been involved in all the steps. And that's part of our process of review, is whenever something is going to be made or changed within the data platform, that we ask for the various committees to review before it moves forward. It's not a perfect system. Everything can always improve. But I think that what we're hoping to see is really trying to put forth the sort of the best people to be on that committee, to really make sure that the work is the most impactful it can be when it comes to sort of collecting the information that we want to collect.
Okay. Dr. Nemiroff?
Well, first, let me say I like Dr. Williams' toy collection.
Yes.
Back there. I'm ready to come and play. So fundamentally, I think what we're dealing with is a situation in which TCHAT obviously was not designed to be a research study. But the data that's been collected is of great interest to the research community. And yes. So you all have done a great job in collecting the data, quality control, and the data now exists. But as Dr. Pliska said, the current data committee is not comprised of researchers. And the question is, who wants to interrogate the database? There are many questions that one would want to ask of the TChat database, and perhaps we should have a conversation among the research committee and other members of the HRI continuum as to who would be interested in taking the lead on interrogating the database to answer some of the questions Maduka raised and others, because it is really important to determine the outcomes here.
And if I may reframe that just a little bit, the purpose is to improve the TChat program.
Absolutely.
Evaluation and figuring out what we can do to make the program versus pure research.
Absolutely.
This is evaluation, outcomes, quality improvement.
Absolutely.
Yeah.
Yeah, I think, Charlie, I wouldn't totally agree that all that needs to be done is to interrogate the database. The data, a lot of the data that's in there is not ready to be analyzed because it may never be. Some of it is just has so many problems with it because of the way it was gathered. And that's one of the things going forward. I think the data committee not only needs to have people with the expertise, but also that kind of will weigh in with to make some of the corrections that need to be made. I mean, there is data in there that's going to be very valuable, but a lot of it, when we tried to look, say, at changes in the PHQ-9, we just discovered there were just so many variations by site and by when it was done and where it was done that it would be very tricky to put it together and say that any of the changes we saw are something that is publishable. So it relates to standardizing some of the data gathering procedures across HRIs that, again, I think belongs with the data committee and needs to have some degree of authority.
And Dr. Liberzon, and then I'm going to jump in.
Okay, so I try to be specific about the questions. So I believe what you need in data committee at this point, probably needed from the beginning, but I will not be. In Russian, there's old sayings. I wish I was smart as my mother-in-law after the fact, So it's good to be in a hindsight. But what I think data committee really needs is bona fide bioinformatics person and bona fide implementation dissemination researcher. They don't have to be necessarily part of the team so far, but they need to be a very well understanding their roles, and they have to be expert, because first part that is will need to be done, in my mind, it's a large work, but it's worthwhile doing and thinking about it. I call it data dictionary. And the data dictionary has to include all pieces of data and describe how the things going in, what's the quality of the data, and what the confidence level that we have for each data. And based on that, the implementation researchers can tell you what kind of questions can be answered. And based on that, then it can be open up for actual interrogation processes. Because other than that, that will be one off each thing and one off each time deciding, is this piece of data valuable? If that piece of data valuable, is that reliable? How many people will be able to ask questions there? So to me, at least two professionals that deal with data, bioinformatics specialist and two implementation and dissemination researcher specialist. And the first step for everybody is to create and start working, and it might take 6 months or so on, but creating data dictionary that will review the data, what's the potential reliability and variance in that, and decide what type of questions we probably will not be able to answer.
I think we do have a data dictionary. Just want to share that with you. We've worked on it from the very beginning. That's one of
We also have 2 evaluation teams who've been helping us with this work. So I actually don't fully agree with some of the how this conversation is being characterized, but I do think there's things that do need to get improved. And I do think that one way we can do that is actually discuss, how the data governance committee structure is and who might need to serve on it to assist in that process.
So I'm going to go to Lachelle and then I'm going to jump in.
Yeah, I just want to add, Dr. Librazon, agree about needing a very robust data dictionary to inform our analysis moving forward. The scope of work of both the internal evaluation team and part of the external evaluation team for this next biennium includes shoring up the existing data dictionary that we have from TRAIT. So TRAIT does have a data dictionary, but it is missing some elements that would be relevant to somebody kind of analyzing the data. And we know that. We maintain a log of issues that we see as we look at the data, and there have been issues, and some of that's process related or training related, and some of it's things that need to be fixed within the TRAIT system itself to reduce the number of inaccurate or information that needs to go through that cleaning process. But I think it would be useful, what we've talked about internally is the internal evaluation team has a scope of work to look at the different services and figure out how do we improve them. We want this next biennium to be very action focused. So looking at things in a very discrete way and then coming out with actions that we can do to continuously improve the quality of the services that we offer. It would be great to have a group that can help inform the direction of the internal evaluation team in this respect. And so first step is getting that robust data dictionary. Second one would be to have some input from people that know about evaluation, helping inform the internal evaluation team's scope of work moving forward into the next biennium. But the other thing that we are working on is getting that data outside of TRAIT. It's not just TRAIT there where we have information. We've got the reports that the HRIs give us. We've got financials, we've got FTEs, other types of programmatic information that need to be in a single database that we can use to analyze moving forward. And so we are working with the internal evaluation team to get that set up to make sure that we have processes documented about how we're cleaning the data, that it's very clear what the definitions are. And it would be great to have a group of people that are actively looking at the data, helping inform.
Quick.
Yeah. So I agree. I'm glad to hear that. Both what you have mentioned, what Alex has said. So if there is a beginning of the things that are there, but then the question is what is missing. Obviously, there is some data dictionary, but obviously some other things that I was suggesting that needs to be there, it's not there. So the data dictionary has to be further interrogated and further improved. Now, I understand that some people are unhappy about what I'm saying, because they feel that everything is good. But if everything was good, we would not be having this discussion right now. And if we're having this discussion, so discussion is how to improve what it is. And I understand that people feel ownership about what happened so far. But if we just be worrying about that, we will not be improving anything.
I think this is, and actually I'm going to go ahead and jump in. I think this is just natural growth of a program. That when 4 years ago, we established the program with TRAIT, put in the elements we needed to move it forward and develop the structure of the consortium. And I think what I'm hearing from Steve is that this is normal growing pains. And it's not related to lack of quality and work that folks have done, but it's just natural after 4 years of thinking through, is the structure right now the right structure of where we need to be for the next 4 years? And are we able to adjust the program a little bit in order to make it where we need to be?
Thank you, David. I want to reiterate what you just said. That's exactly what Steve and I had discussed. I mean, we started out the program with a data dictionary, looked at data stewardship and all these things, and it evolved over the last 3 years. And as we add more nuances to the program, of course, the data dictionary got more scrutiny, and we need to evolve that as well. And the same thing goes with the structure that we have. And that's why we're here, is we're bringing this up, is like, how do we evolve this structure that's in place to actually evolve with the program? And so that's the basic tenet of what Dr. Pliska has put forth.
It's a natural growth of the program. And again, the goal here is to make sure we can tell the legislature, the governor's office, how how we've been stewards of the dollars and the outcomes of the kids. And so, Sue, I'm going to go to you, and then Laura, and then again, I'm going to try to let's map out a path forward and to make us progress. So go ahead, Sue.
Yeah, being new, I just have a question about how I appreciate that we need the data dictionary. We need things to be accurate for research and tracking, but how do we get in the operational perspective so that we know that it can be properly implemented and be useful to the teams that are also using the data from a process improvement and clinical perspective?
Yeah, so I think that's part of the discussion. And again, I think where we're going to go, and Laura, I'm going to have you jump in, but I think what we need to do is to have Laurel and Steve and a couple of other people, Lachelle, and Sue, if you want to be part of that, and a couple of others, to look at where we are, think through what are some of those concrete steps related to structure. The work groups that we have, are they in the right place? And then come back to this group with a formal recommendation related to changes related to structure that would need to be put in place. And by structure, I think there's two parts of that structure. I think one, when we started off 4 years ago, who needed to be on the data committee was unclear in some institutions. And so they, some individuals that got put in may not have been the right person. And that's not to be say anything derogatory towards them, but they may need on this data group a little bit different expertise. And then the second part that I think we need to task is, and where is it structured? Where is it kind of reporting to? And the COSH has a data group. We have this other data group. How are they working together, or do we need to put any kind of structural changes in to make sure that the reporting is appropriate? Laura, let me go to you, and then I'm going to see if there's any questions of kind of what I've just laid out.
Sure, thanks. And I appreciate this discussion. We have been working really closely, of course, because all of the integrity of our results really depend on the data. So we have, always spent a lot of time cleaning data and mapping out our data flow and management plan and cleaning plan, and have communicated our step-by-step process very closely with Dr. Williams' group and internal evaluation team. And as Lachelle said, as a result of 2 years of this process, we have been coming together to talk about refining it so that we all are doing this together. And I do agree that, this was a heavy lift in the beginning to implement right away. So I think trait was developed with implementation in mind. And then as evaluators came in, they said, this is how we need it to be pulled from an evaluator's perspective. I think some of the solutions, talking back to maybe see what you mentioned about, well, what about the user? When we give our feedback on any issues that we identify, and we've tracked them all, we go through them, and some of them are, this can be improved by improving the trait system, and this is a user retraining issue. And so we have those two different kind of solutions in mind. Also, just to reassure that there has been this process that has been developed along the way. Again, from everyone's kind of collective experience with the data, we have been trying to very much so communicate so that we're leveraging everything we're learning. But we're happy to present our data management and cleaning plan, to this group in the future, if that helps. And also to also reflect on kind of the data we give back to you. You'll notice sometimes we have basically a paragraph under a table, because we say exactly where the data came from, what the dates were, and how we defined or operationalized the data, so that it's very clear what our findings represent. And I just wanted to underscore that, so that when you do look at the data we provide, those caveats are there in place, because someone might define it differently for their analysis, but it will help to compare those two analyses to know why the differences may exist. But I just wanted to give that kind of reassurance and kind of the reflection from our experiences on the program.
Thank you, Dr. Savas. Dr. Ibrahim, and then Dr. I'll go to you.
Yeah, I agree with Dr. Lakey. I mean, it's just a matter of natural evolution, how we started and where we are now. Perhaps something to consider, as you mentioned, 2-3 more members. We have several researchers on the executive committee who've been involved since day one and have experience in data structure and data collection. Perhaps just it's a call, perhaps, to some of them to get involved in this.
Hey, can I say something to that last comment? Is that one of the things that Steve and I actually talked about too, in anticipation of bringing this up, was that in redefining the structure or evolving the structure, that's probably a better way of describing it, evolving the structure. It may entail that we have new leadership at the Data Governance Committee, and we're completely okay with that because we believe in the evolution and we believe in the purpose of this data committee, and it requires different people who participate as committee members or as chairs or co-chairs, then we are very much support of that. So it's not about us trying to protect some kind of fiefdom. It's about us trying to evolve this into a format that actually helps and supports the consortium. And so just want to throw that in there.
Yeah, I agree with that. I agree with that.
Jeffrey.
Yeah, I agree with everything you had shared, David, but I wanted to point out and add a comment that I don't think that's mutually exclusive with the points that Israel was sharing before. And I agree with you absolutely that, an appropriate next step would be reviewing the structure of the database and determining what modifications might need to be made. But I would say at that point, to piggyback on what Israel said, it is really an ideal time to have someone with top-level bioinformatics expertise to be involved in that step of the process, not later.
Israel?
Yeah. So I have been in this position each time I finish a grant. I look backward and say, I wish I knew something before that. It's a normal process. That's what I'm highlighting. What I was saying is not to say, somebody made a mistake, so didn't do that or didn't do that. We're always in this position. When we get to the end of the grant collection or project collection, we look back and we say, if I just did that, or if and that's a normal process because we learn and we try to improve for the next time and so on. So I don't see that as a particular negative comments, but I do see that as a realizing that this is the process that has to be done. And we all recognize that this is critical moment. Now, more importantly, to what Jeff just mentioned, bringing people who are specifically in the bioinformatics will help to try to look in how we expand or how we continue data collection, because that's not the end. It could be that we have some processes that can be simplified and improved that will be helping all of us to continue collecting the data. Now, what I still not entirely sure, maybe that's one of the issues that are complicated here. So we know that evaluation, both internal and external, are made not to the purpose of publication necessarily research. It's made for the purpose of demonstrating effectiveness and improving the processes and so on. However, it's not surprised that within these groups of external and internal evaluation teams, people with this expertise that I was talking about. So my question is how, and maybe I don't know, but how integrated these processes are with our data collection, or should they be more integrated? Should we pull more people from the evaluation team, participate in that process? And I don't know which team has more of those individuals, rather than having those processes communicate with each other, but each one going a different direction. So to me, that's a kind of a low-hanging fruit, saying we already have people involved in similar processes, we already have people with expertise, and we pull them in as a part of our data team immediately and start working on expanding the data dictionary and looking on the quality through it.
So I'm going to go to Dr. Trivedi, and then I think we need to wind up this conversation and move forward. But so Dr. Trivedi.
I think this is not as complicated as it sounds. And Dr. Williams is right. A lot of the necessary things are actually being already in place. And we have a lot of experience with this. And actually, Dr. Wakefield is doing one of our things with them. We have done a lot of this work where you are actually trying to improve / change quality of care, and in the process introduce the idea that you got to measure what you're doing and then figure out how to interpret that data. I can send you enough papers on this. So I think Dr. Williams is right. We already have a lot of the sort of scaffolding in place. The idea is to figure out how to then put some changes, but then begin to analyze and interpret these data. I'm happy to help, but you don't need to include me. But I think this has been done too many times. It's not that complex. You cannot enforce exactly week 2, week 4, week 6 assessments. This is the nature of natural quality improvement project. I think people have done this. We've done this too many times, and happy to help.
Okay, very good. And so again, I think this is natural progress after 4 years and figuring out what our structure is and the composition of the committees. Laurel, I'm going to ask you and Steve to work together. Alex, be part of that, to come forth with some specific recommendations related to structure, expertise of how do we move forward, not the end solution of everything, but the high level things that an executive committee would need to bless to move forward. If there are some other individuals that need to be part of that conversation, if you would let, I guess, Luann, have them send it to you. Now, I'm not going to put every executive committee member on a work group to try to figure out how do we do this. It needs to be smaller and to give some specific recommendations. But that group isn't going to give us all the specifics, but what we need to work out is structure. And if there's any changes in structure and composition for us to have the right organization to move this issue of data forward. That sound reasonable to everyone?
Oh, the 3 of us, or do you want to include anyone else initially?
If anybody else wants to, they will let Luann know. But I said I'm not going to put everyone on the executive committee.
Right. No, I agree.
For multiple reasons.
I was wondering if Lachelle and Molly would want to be involved.
Lachelle is definitely going to be in the middle of it from our end, and Laura would probably be asking you to be part of that, and our internal evaluation. Again, a lot of implementation science expertise there, but the main question right now is structure, and then once we have structure, we can drill down further.
Very good.
Okay.
And I will just
We will
add
do
that
that.
we have several projects that are planned for the next biennium focused around data dashboards, and we've got a project plan for those, starting to be built. First step is the data dictionary. We're starting to define who are the people that need to be involved in these projects. So it seems like a great opportunity to figure out if there are other people within the HRIs that could be a part of this project as we move forward, defining what the data dashboards, what the process needs to look like to maintain those moving forward.
So let's pull that all together and have this group come with some specific recommendations, and then we can move it forward from there. Sound reasonable?
We'll do it.
All right, very good. Dr. Wakefield, you want to give us an update on PeriPan?
I am happy to. Let's see. Let me see if I can find the slides. I think somebody there has my slides, right?
Lachelle's pulling them up right now.
Great. Thank you, Lachelle. We'll be pretty brief today. You guys know where, well, yes, we want to say as of September 1st, we are now statewide for PeriPan, which we are very, very excited about. So no longer are we using our map with our 4 pilot regions. We are using the same map we are using for CPAN. So I want everyone on the executive committee and beyond, and all of those listening in, to know about all the amazing work that we and all of the teams and the HRIs have done to make this possible. It really has been a phenomenally collaborative experience to really answer questions, say how we're going to roll this out at each HRI, those that have a reproductive psychiatrist ready to go, those that don't, those that felt like they had other reproductive mental health clinicians there as experts, and those that didn't, and how we could all really work as one team statewide to roll this out. So I cannot be more appreciative to our entire team, Kosh and the UT system support, and then all of the CPAN teams at every HRI for getting this. And Jen Erdegi, who is the program director for our statewide PeriPAN program. I've just been in awe of all of the work that's been done here, and we are statewide. So we should celebrate that. That is really exciting. So that was the point of this map, because you guys know where the state is and you know what we've been doing in CPAN, but now you can see that we're doing that in PeriPAN as well. And also really integrating the CPAN and PeriPAN programs together to utilize the infrastructure that we already have, to be the most efficient with our service and with our dollars. So we still have the separate dollars for ARPA, for our PeriPAN services, and our GR for our CPAN services. But trying to stretch all of those dollars and do the very best planning that we can to make this sustainable and an efficient and effective program. Okay, next slide. So what have we been doing? We've been doing lots and lots of stuff. David Lynch has been, I really, this clinical universe is a new term to me that I didn't have internalized in my brain before he used it. But David, it's one of my favorite terms that we have to define the clinical universe. So what that means is David did a lot of work looking at the Texas Medical Board OB list. We defined which of those specifiers that we wanted to include in our list. And then David looked at all of those lists, distributed them to all 12 HRIs, gave updated lists to our pilot sites, and then initial lists to our incoming sites. There's still a lot of work to be done around those lists. All of our HRIs are working on vetting those lists, trying to see who actually is providing obstetric care and who is not. So there's a lot of work around that, but we are having one-on-one meetings with every HRI to talk about those lists, how to update those. And then David put together a phenomenal spreadsheet that I think will help us. We are using, I was just listening to all of this data conversation, and we are using all these lessons learned and this natural evolution of these projects that we're doing to just the iterative process of making things better and better and better. And we have taken everything that we could have possibly learned from CPAN so that we can implement this anew with PeriPAN and revise things with CPAN as well. So it's been a fantastic learning experience. But we have this beautiful spreadsheet where people can delineate if that clinician is eligible, if they are in the right region. If not, we can track that data and get them to the right region, or we can not put them on the list to re-engage if they're ineligible. So I think it will help teams with efficiency and targeting communication about our projects in the future. We are collaborating. We continue our collaboration with the Center for Healthcare Communication and with Lifeline for Moms. Again, so the Center for Healthcare Communication is Melanie Suswine. We've already heard from her today and her group who are helping inform our decisions and how we have these programs work together, how we talk about them together when it's appropriate to talk about them together and when it's not. And then also we continue to work with Lifeline for Moms, which is that entity that sprung up from MCPAT for Moms, the first perinatal access project in the country to really help states develop these programs and take the lessons learned from nationwide and implement them. And so that's been a great collaboration. We are working, when you look at social media posts, we are utilizing the CPAN pages and not creating new pages, but creating new content and looking at when we should have combined content, when we have separate content, how to get our message across and focused and targeted. And then I do also want to say that we have direct consults, meaning if we are talking with a clinician And we're unsure of the diagnosis based on what's been said to me. So when I take a PeriPan call, I hear from a clinician, hey, mom comes in or mom to be comes in, she has a bipolar diagnosis, but I really don't hear anything that makes me concerned about bipolar disorder, but she has a lot of trauma. Before I give a recommendation on a medication or an intervention or a therapy, I want better diagnostic clarification around that. I know that the obstetrician doesn't have time to do that. So we can have that woman engaged in a direct assessment via tele that is available statewide. I have to commend our team at Texas Tech for doing those direct consults, and there are other pilot sites for working towards going live on those direct consults. But we've established a protocol where any HRI across the state can refer for a direct consult, so that we are not having that isolated and only available in one area. We know from Lifeline for Moms that this drives utilization. The direct consult specifically, the availability of that drives utilization of the Access Project, and we just know it's good practice. So I'm really excited that as we went statewide, we were able to also take direct consults statewide. All right, so we also continue our development. Our grand rounds have always been available statewide for PeriPan. Since we went live, we knew that we didn't want to restrict those to the pilot sites. We continue with, we have 3 more grand rounds for October, November, and December, and then we will start over. We met with the experts across the HRIs, both child psychiatrists and reproductive psychiatrists. And we all decided that we wanted to redo that initial curriculum that we had for the last year, so that as we increase engagement in our program, that more people will be able to participate and attend those webinars. And next slide, I think that's on the next slide. Back one. Yes. So here is our lineup already in place for 2024. And we have clinicians, experts from all across our HRI continuum helping us deliver this content. So it really is a collaborative process and project from the entire state. And I think we have just phenomenal content in these webinars. They are open to anyone who is providing and engaged in obstetric care, are including postpartum visits or new baby well visits for pediatricians who are screening moms, to our internal folks who might want to increase their reproductive psychiatry or reproductive mental health knowledge as well, and also to residents and fellows across the state. So these we want, we just have a great lineup of all kinds of different reproductive psychiatrists and experts providing this, addiction psychiatrists, serious mental illness psychiatrists, eating disorder experts delivering this content. So really excited about that. And then next slide. We have also taken our ECHO project now, which we had limited to our pilot sites, just so that, because these are supposed to be smaller learning communities, and we didn't want to get them so big that we couldn't actually facilitate them in the ECHO model. But now that we are statewide, we are open statewide for participation in ECHO. We have a spring series and a fall series. Our fall series is underway. I have to remember what season I'm in. Our fall series is underway right now. So you see those topics here, and then we will start over with our spring series in the spring. Next slide. That's it. So I'm happy to take questions about this. We have lots of HRIs in different stages of development with PeriPan. So as we meet with them one-on-one across the state, we have different things that we're discussing. But it is, and so we will be able to provide you some additional data, but I thought this was the best update for today.
Are there any questions? And the data, will Laurel have some of that data related to, did you have any sense so far about how it's being used, and kind of is volume picking up like we think, or is there anything we need to be doing in order to get utilization up, or any information like that?
Sure. So volume is picking up. It's not where we want it. I will say that. And so I think both of those things are true. When we talk with our consultants, they're happy with where that we are. They say some states it takes months and months and months to have a first phone call. And every HRI that we've talked to in our one-on-ones have had some sort of peri-pan phone call since we've gone live 1 month ago. So we're really excited about that. However, we are also actively looking at additional engagement strategies. I'm really excited about the work with the HHSC on this perinatal substance use and the education around that and being able to refer women for this service. Additionally, we're talking with Lifeline for Moms and the Center for Healthcare Communication about engagement and developing a list of doc-to-doc kind of presentations. We have developed a combined ethics CME with CPAN and peri-pan that can be delivered clinician to clinician or to big groups so that we can talk about peri-pan and CPAN. We're looking at the different professional associations that already give both newsletters and have, CME events in Texas and how we can best utilize a collaboration there to get our message out about what we have. So both, yes, we see that all HRIs are receiving calls, and that is very exciting. We want us all to receive more calls, and we are working on how to provide and how to facilitate that engagement.
Yeah, it'll come with time, right? The experience with CPAN, if you look year over year, continued growth, it's just again something we're going to need to track closely and be transparent on, so we can make sure we again coming this time next year make the case to the legislature for the full investment. Dr. Trivedi?
One thing, this is so exciting, Dr. Wakefield, and but I have a question related to it, and that is, there is this big movement in peds work where, especially when they come for immediate postpartum visits, they get screened or etc. How is that incorporated? This is exciting. So will they be able to call and get services? How do you do that?
Yeah, absolutely. So a pediatrician can call and they have been calling. We have received plenty of calls from pediatricians. I presented that data before, and yes, Dr. Lakey, we will present that call data in the future. We've been looking at that. Pediatricians are our second highest utilizer of CPAN right now when we look after obstetricians. And so we provide both education and CME to them, but we facilitate their phone call. And sometimes they are concerned about mom. Mom may not need a specific intervention, like a diagnostic assessment. Sometimes mom does. And then we'll work with whoever was providing mom clinical care before. I've had calls from pediatricians where mom doesn't have a consistent, she didn't have a prenatal caregiver. She delivered and she doesn't have good postnatal care follow-up. And so we'll help arrange that. We'll help get her in with someone who could do that, get her referred somewhere. But also there's so much evidence in reproductive mental health about mom not feeling isolated and how that decreases symptoms. And so we're able to refer to lots of groups. We're able to facilitate parenting classes, or recommend these different things, but also access to Postpartum Support International and say, hey, there's an online group that mom can access. So we're trying to look at all of the different potential resources that can really wrap around mom and help inform what a pediatrician might be able to tell mom or have in a packet that's not, that might require, they might not need to call peri-pan in the future, although we want them to. I will say we are very, very close on a toolkit, and the toolkit will be posted on our website. It has screening packets that we recommend for mom. It has resource packets that we recommend really to be distributed to all moms. It has safety plan recommendations in there if mom is feeling overwhelmed. And so we're trying to really push out the ability for clinicians to incorporate things into their typical practice in their clinics.
Very good. Any other questions? Octavia?
Sarah, really exciting and quick scan as you were showing the grand rounds for peri-pan, and maybe it's embedded in there, but I didn't see anything in relation to say like health disparities in maternal health and stuff. Is it embedded, or because I didn't catch any of the titles, but I didn't scan it completely. So maybe it's there and I just missed it.
Absolutely. We've absolutely had that conversation. And to me, that is not a one-time presentation that needs to be incorporated and embedded in all of our conversations in each education.
Just to follow up, so you do have some that are addressing those issues?
We do.
Okay, good.
Again, congratulations, Sarah, to you and everybody. We're a month and a half into the statewide rollout of PeriPan, and like any of the rollouts, you start getting momentum, and we will continue to educate people throughout the state related to the availability of PeriPan. And again, it's the lessons learned from CPAN that it will continue to build upon itself, and look forward to all the success. Anything else, Sarah, before we transition?
Nope, I think that's it. I'm always happy to have these discussions and any input or recommendations or ideas. But I've been very, very privileged to be a part of this and all of the momentum and the support behind it.
Very good. All right, Dr. Williams, let's go to you for the update on the COSH activities.
Somebody has the slides for me. Okay. Can you go to the first slide? I just wanted to make sure that I wish you guys all a nice holiday. It's finally decided to be fall, at least here in Houston. And so, you know, you can have at least one piece of candy this month for good behavior. So next slide is, we're going to talk CPAN. So next slide. Next slide. So we're just going to go over, this is what we have on the agenda for CPAN today. There's actually a number of things that we've been working through. And a lot of times when I say CPAN, I also myself just getting more up to speed with the CPAN plus PeriPan. So pretty much almost everything I say here related to CPAN has some almost direct, it actually directly affects PeriPan or has some connection to it. So next slide. One of the things that we certainly recognize as an area of improvement for CPAN was that even though all the teams were doing an absolutely wonderful job with providing resources to families and PCPs, we did want to start to have a little bit more of a central process, A, to both help teams develop their library, and B, to sort of review and make sure that it's truly providing the most up-to-date evidence-informed information that we could give to primary care physicians, who then for themselves, as well as anything they may be handing out to families or parents. So we started to use a process where we developed a work group process. And what we've asked is for each of the hubs actually to participate and have one member of their hub participate. What that person does is then helps collect all the information that their hub is currently providing as far as resources in a particular topic. And then what we would do is, once we've gathered all the information that we've all been utilizing across the state, we then would ask for each of the HRIs and the department chairs to sort of say who in your HRI is an expert in this particular area, because we wanted to make sure that we presented the information to experts in this specific domain for their feedback, as far as, are there any documents here that you think are maybe outdated, maybe are not as good as another document, as well as are there any documents or materials that we've missed that we want to make sure we have sort of in this sort of library of resources. So we do have the documents sort of reviewed out in a couple different ways, ones that are just for PCPs, ones that might be for a parent, one or a patient if they're a woman pre or postpartum, and then also not just for a patient in adolescents, because as we're aware, CPAN works for children of all ages. So we want to make sure any resource that we're providing and also is appropriate for the age range as well. And so we wanted to make sure that everything we did there really helped us sort of have the highest quality. And so the teams would obviously collect data from a lot of different sources, including our non-for-profit sources, HSC. So we're not limiting ourselves just to one place that we're looking for it, but we are asking for experts in the field to kind of help us vet those lists and make sure they really are the best list they could possibly be. And we sort of have a cadence that we're going to set up where we're going to hopefully walk through each of the sort of major diagnostic categories within child mental health and obviously with the perinatal kind of in that space as well. So the other thing we want to really make sure we do is keep all the resources that we actually said we didn't think were the most up to date. So that way we can help reduce sort of people looking and then finding something and then trying to potentially utilize it, or we have a process additionally where you can sort of say, hey, it looks like you missed a resource, because we always want to make sure that we're making improvements to the data. but we want to first have teams check against what was already kind of put in the pile of no, maybe these are discarded resources. So we're trying to keep the resource list as fresh as possible, but also allow for an opportunity for new things to come in as people across the state find new resources for a particular topic. Next slide. So the first one we did was the eating disorder resources. We started that one because it's for better or for worse, it often has a little less resources that are available for people to kind of go to. So we use that as sort of our test case for doing this process. And so now the resources are on our team site. Edith kind of worked with the HRIs and along with Lachelle to kind of create a process where these resources can reside in a way that will make it easy for teams to access and utilize. And so within that process, across all of the different categories of PCP, patient, family, ages, the sources, the types of materials, we approved 120 resources within that eating disorder topic, broadly speaking. And the next topic that we're doing currently right now is psychosis. So once again, as an HRI department lead, you may be getting an email that's asking for you to identify people at your institution that are experts in a particular area who would have some time to kind of go over the resources and make sure that we are putting forth the best resources possible when it comes to information. Now, these resources are not treatment providers. This is materials about disorders and things that might be important for a PCP to know, or things that a parent and or a person who's suffering from the disorder or issue would want to know. So I just want to give you that update as far as how we're working together across that process. Next slide. The other thing is that we have been working with our 12 HRIs is in addition to the UT system with Lachelle to kind of help to improve our networking database. So this is a slightly different process where this is actually people that can provide services. So we have finalized the sort of the upgrade that we want to have with WellNeti, and we are in anticipation of having teams do a bulk upload of their resources. Now, again, this is extremely critically important as CPAN becomes busier and as PeriPAN comes online, that we want to have one database, one resource place that people can go to find things. So if Baylor happens to be covering for the Lubbock region one day, we don't have to delay in getting that OB their information they need, because we'll be able to see the same list that everybody else is using. So we can go and look in the Lubbock area and find the information because it's there for us to find. And we don't have to give work to Lubbock the next day. Plus, we also can provide that resource as quickly as possible to the provider. So this is why it's really important for teams not to squirrel away their own resource list, but really have it sort of be in one. So we've made the sort of process to make those improvements was very much involved the UT system as well as all the HRIs. And we are excited to sort of see that now that we can get the contract finalized with WellNeti. It's going to take them, that team, about 8 weeks to do the upgrades and the build out. And then the teams will have it turn in their internal less bulk review. And then we will do product launch probably January sometime. And before the product launch with the new features, we will do training with all the HRIs to make sure that everybody understands how to best utilize the platform to find referral sources for families and women and kids. Next slide. Again, the new process that we all approved as far as how the calls come in. Again, remember, we wanted to make sure that thinking about what's going to be best for a physician, NP, PA calling, that we wanted to kind of make sure that it was seamless on the back end, that they now are hearing a recorded message if they have to wait for any given time, to kind of give some information about CPAN, PeriPAN, but also allows us to move it to another hub quickly if one hub happens to be taken up with a lot of calls. But as you can see here, that most calls for CPAN/PeriPAN are picked up in 12 seconds on average. So we're not really having trouble with the primary care physician getting to reach us very quickly. And then about 7% of the total call volume is being transferred at that 3-minute mark to a new hub if needed. But again, that's again much more of the outlier than 12 seconds on average being called. And we look at sort of what kind of service tickets we sort of have with our vendor related to the communications. Largely, the volume is about hub coverage. And we made a deliberate decision at the very outset that we weren't going to sort of let teams change the call tree without sort of trades, without the vendor's assistance. So that's why, again, if Baylor needs somebody to cover them for a Monday because we're out for a team training, we put in a ticket to sort of have that the hub covered by another team. So those are the volume is primarily for that process. Next slide. So with the circling back to that earlier conversation related to changes to platforms, we did in the process of improvements for data collection, as well as I think Sue had said well, how does it operate for the team? So sort of the dual purposes of both making sure the program runs and also getting the data that we want to get out of the platform. We have made some changes, and again, the process involved with for changes for any of our data systems involves the UT system, the internal evaluation teams, the data governance team, as well as the operations team. So there's actually a pretty comprehensive process right now before anything is changed or developed to make sure that all the stakeholders are involved. To that end, we did have to make some changes from the evolution of the beginning of the program in 3 or 4 years ago now to now. All of the medication changes, or how we're collecting information around questions related to psychotropic medications for CPAN, have been signed off, and the call forms are being updated, and that is moving forward. The other things were actually related to process flow, and sort of back to Sue's point about how to make it run as smoothly as possible. There were some changes to the call forms, the referral, the triage form, and then the actual bulk of the call form part 2. Again, all of the relevant committees were involved in these changes. It's one of the reasons why it took as long as it took. Actually, it took over 6 months to make these approved changes, and kind of walking through all the various committees to do that. But nonetheless, all the committees made their reviews and signed off, and the trade vendor is now working to do that, those changes and those updates, and we anticipate that those will be ready for November. Because these are pretty massive changes, we are going to do a whole team training in the month of end of October, early November, to make sure that everybody understands how these changes affect them specifically to the type of team member they are for the platform, because it does affect sort of people who take the calls, people who find the resources, and the physicians who provide their input. So we will do a pretty massive training as a result of this. And so we're excited to see those changes, and it's been a long time coming. For those of you who've been, hey, when is this happening? It's finally here, it's happening. So we're excited for that. Next slide. So one of the questions that we've had is about sort of user engagement and how to help the primary care providers utilize the service more. We had put aside some ARPA funds to potentially develop a PCP portal. So right now, primary care physicians can reach us via phone call, reach us via text. Again, no PHI, but they can text us. And also when we do in-person meetings, either to enroll them or produce CME activities. So there's actually 3 different ways currently that a provider can start a consultation with CPAN and PeriPAN. But nonetheless, there was a conversation about that sometimes PCPs might want to provide the consultation after hours. And so we did work with the communications team and Melanie Susswine to develop a series of sort of conversations with providers who are enrolled in CPAN, but who have never used the service. So we didn't want to talk to super users. We actually wanted to talk to people who weren't yet using the service to understand if whether or not a portal would be something that would increase their engagement and their utilization of CPAN and PeriPAN. So we used sort of industry standard questions. We had sort of qualitative interviews that were recorded so people can go back and review them. And sort of the take-home point that we found was that a lot of the people who were enrolled didn't actually know they were enrolled in the service. So just me telling them specifically about the service made them excited and were happy that this service existed. But specifically the questions about a portal, would that help you use it, not use it? What would need to be in a portal for you to feel like it was beneficial to you as a provider? We found several things that were extremely important for PCPs across the state in order for them to consider sort of increasing their utilization. One is definitely a portal that could allow them to put in their consultation requests after hours. The other one was for them to have written documentation of the consultation so that they could either just see it for themselves or download it and upload it into an EMR if that's what they wish to do. And then also have a way to just have a portal that would have the resources that we already send, like via fax or email, that they could just sort of have. That way they could go find it again if they needed it. So those are the things that when we sort of walk them through several different types of things that could be in a portal, these were the 3 consistently high high value items related to a portal. So we are working again with all of our relevant parties and systems, including Dr. Tran, who is our PCP a pediatrician advisor, to sort of really walk through what would need to sort of happen in order to build a portal in such a way that a primary care physician would utilize it. So that process is moving forward. Next slide. Again, to Dr. Wakefield's point earlier and Dr. Lakey's point earlier about sort of increasing utilization, one of the things that we hear a lot from providers is A, they don't know that they are actually enrolled in the program, and B, they sometimes don't really understand how it could fit or how it could work into their workday. And so Sarah and others and myself, we developed a presentation specifically utilizing the framework of ethics, because that's one of the Texas board's required types of CME activities that primary care, not just primary care, all physicians have to do. So we thought if we sort of were able to create a presentation that was very specifically focused on getting them CMEs for ethics, that would be another way to kind of entice them to come and listen to the presentation. And we will do the presentation with one provider if needed, or a whole group of them. So it's really catered to trying to be as mindful and respectful of a PCP's very busy time as possible. So we had both a 30-minute one and a 60-minute one, depending on the amount of time that the PCPs felt that they had to sort of dedicate to a CME activity. And again, the focus of the presentation really discusses the ethical imperatives for primary care physicians to get involved in collaborative care, of which CPAN is a type of collaborative care, and that it ends with the primary care sort of doing an exercise for themselves and their team about what would it take to kind of help them think through how to start utilizing collaborative care in their own specific model of their own practice. Because we always know to start a new behavior is very difficult. And so even if you think it's a really great idea, sometimes the next step of thinking, okay, it's a great idea, but how do I make it work in my workday, is where a lot of times I think we're seeing a little bit of a struggle. So we're hoping that this presentation can help. And as we said, we've developed it such that it could work for both OB-GYNs, family practice, pediatricians, and PAs. So it really is sort of the sort of known universe of people who are enrolled in CPAN and PeriPAN and who can use the program to its benefit. Thank you. Next slide. And then similar to Dr. Wakefield and PeriPAN, we continue to have our fall and spring echoes. Generally speaking, we've already started the Project Echo for CPAN this fall, and you can see here the upcoming presentations. We've gotten some feedback from a few of the teams that they like to potentially, before the next fall, go back and do some updates to the slide decks, and I said absolutely happy to do that. So we haven't felt the need to create new presentations for fall or spring yet, just because there's still so many more providers to sort of get some of this materials in of itself, but in general, the feedback related to Project Echo, as far as CME, the sort of feedback from primary care physicians is that they find it valuable for them, and so we haven't needed to start adding new. And beyond the Project Echo, obviously most teams do have additional other types of CME that they're doing within the month. So we also want to make sure we're coordinating with teams to not overwhelm them with the number of CME activities that they are being asked to do. But you can see here in the fall, both session 1 and 2 had a reasonable amount of learners. And as Dr. Wakefield said, Echo is not meant to be these huge audiences. They're really meant to be small audiences, so you can have more deliberate conversations related to sort of more nuance about a particular issue or concern. So next slide. As you can see here, this is the growth over time that Dr. Lakey was alluding to, and this growth now starts to include the OB-GYNs. Obviously, we enroll more than just OB-GYNs that Dr. Wakefield wasn't able to share, but we enroll midwives, nurse practitioners, PAs, family medicine. Peds were already quote enrolled, but now we're telling them that they can also now utilize PeriPAN in addition to CPAN. So we anticipate to see that growth continue as we start to add all of those different providers, including actually general psychiatrists who are working with women who maybe are like, well, I don't really remember that well. I'm at CPAN or PeriPAN, maybe I give them a call. So we provide that help. But who we keep track of from a metric perspective are the OB-GYNs. Next slide. And then to Dr. Lakey's point, this is specifically CPAN volume. It's not PeriPAN yet. But as you can see from year to year, we've continued to have pretty consistent growth with our CPAN call volume. So we're excited to see that. Next slide. So moving on to TChat. So referrals since the program start. Now, again, this is the data that's already been discussed, so I'm not going to spend too much time on it. Again, it's just sort of another way of looking at the visualization that as TChat has started from 3 years ago now, we've seen phenomenal growth from year to year. So we're excited for that referral pattern. Next slide. So again, one of the things that's very different about CPAN versus TChat, which I'm sure you're all aware of, but it always bears reminding, is CPAN is really meant to be a process that's very similar. We do not want to have lots of big deviations with how the service is delivered. But with TChat, there was always the sense that there's regional differences. There's different ways that teams have put their team structures together. So it actually becomes very challenging to consider how you're going to do some of the things that we've been talking about, because if teams have different definitions of referral for themselves, then you can see where you start to have challenges. So kind of some of the conversations we've been having is what things could be standardized, what things should be standardized, because they may not be the same thing, could and should may not be the same thing. And then how do we coalesce around that? So then we can decide sort of where we're going to go in some of these directions. So all the teams are working enormously hard. And as you see, the referral pattern, everybody is experiencing a lot of very quick growth in doing clinical services. So we're very excited for that. But one of the things that we're probably going to work on first is sort of a strong process for triage with the referral system to make sure that we can really potentially get referrals in as quickly as possible, but also potentially work across TChat lines if needed. If ever a TChat team gets backed up, if another team has the ability to take on some cases, that we can do that. So that will that process is most likely going to be the first work group that we do, is a process around the referral mechanism and triaging. We obviously work monthly with all the teams to communicate these changes and to help them think through what they're doing with their referrals. We've been partnering with UT System to conduct site visits with teams. And then we are helping we had a recent statewide conference where we started to try to work to continue to reach out to that 27% of schools that have yet to sort of officially adopt TChat and sign an MOU with our teams. So we're continuing to work on strategies of an outreach and engagement to sort of have every school system that would like TChat to have TChat. And certainly using the data, as all the people have suggested, to really make sure that we're looking at things from a quality improvement perspective and make those changes that are going to be important to get the services out there to the kids in need. Next slide. So as a few people have said, we have some current initiatives within the data management. We did make a decision to utilize the Columbia Impairment Scale last spring. And within that decision was sort of putting that within the data management platform. We're also now it's already been in the platform since the beginning of the school year, but we've been working on is actually the automation of reminders about it to make sure that the data does not, that we don't miss sort of the opportunity to collect the data. So that is currently also slated to automation to be ready sometime in November. We also did make some upgrades to the medication tracking for TChat, and it's also planning to be out and ready in November, and the school portal dashboard and school staff upload. So I'm going to go to the next slide. So as I said, I was talking through it. So this is, again, this sort of idea that we're going to have the Columbia Impairment Scale be but currently the one measure that all teams will be collecting. Already teams are collecting a lot of different measurement-based care. So most of the teams are doing different versions of measurement-based care, but they're using, for example, PHQ-9As, they're using Columbia Suicide Severity Rating Scales, they're using Connors, they're using SCARED, they're using GAD-7. So a lot of teams are doing measurement-based care, but they're doing it in different ways. And so that is the one thing that we agreed upon was the Columbia Impairment Scale at the beginning and after every third session to try to get some sense of how impaired children are coming in and whether or not there is a movement to improvement as they're moving through. Next slide. And as I said, we went through a sort of reiteration of improvements for the medication tracking system, and that is also set to go live in November. Again, one of the things that was really something that we were working to standardize as well, and within TChat, is most school districts wanted to have information about the number of referrals and sort of directed PHI information, but sort of more information about it. And teams were providing a lot of different ways to do that process. So we all came together and agreed upon what would a school sort of need to see, want to see that would be helpful for them in sort of partnering with us in development of doing TChat services. So the school portal has been available to all school districts now for several months. And we continue to partner with the school districts to think through what additional information would be important for them to have at their leadership level, all the way down to the individual council level. So, making sure that we're always having patient privacy in the forefront. There's a lot of sort of views that they can see that's aggregate only, that allows them to really understand their utilization of TChat services, and allows us to know so that we can partner even more closely. Let's say, for example, we're sort of noticing that a school hasn't been referring to us as much as another school. This could be a signal for us to go and kind of communicate more with them. So these are things that we've been sort of agreed upon to kind of help schools understand how their utilization of TChat goes. Next slide. And that's it. Ta-da! Questions?
Very good. Are there any questions for Dr. Williams? All right, Laura, I don't see any hands up. So again, thanks for all the great work. And it's good to see that the volumes continuing to go up on all the programs. So thanks to everybody that's doing that work at all your institutions. All right. All right, I still don't see any hands, and so we will move forward. Lachelle, let's go to you next at the update on the TChat report.
Sounds good. And this is just data as of the end of August. So we did just get the September data, but we haven't had a chance to review it. And Molly normally goes through a process of cleaning and vetting before it goes into our dashboard. But we are continue to see significant progress in rolling out TChat. As mentioned by Molly earlier, we now have that 27% that's really remaining for us to target. So 64% that are active with TChat. Some of those have districts and schools have declined or are receiving other types of mental health support. When you break it down into where we're at in that remaining piece, we do have around 7% that are pending MOU execution, 6%, almost 7% that are in that onboarding status. And that means that we're waiting to give them training and roll out services to the school. Sometimes it's a case that the school isn't quite ready to begin. Sometimes it's a case that the HRI is staggering that training and deployment. There is a portion, almost 8%, that have been unresponsive to outreach. And so we do meet with the TEA monthly to talk through the districts and the areas that we are struggling to connect with. And so we partner with them. We make that information available to them and to their ESC leads, so that they can hopefully help us identify whether those districts would like to proceed with TChat or not. Anybody can decline and then decide to come back and get services. And I think in some cases we have seen that happen. The other thing I want to mention for this August report, and then obviously the September report, Molly, Dr. Lopez from our internal evaluation team just went through the process of updating our census data. Every year, the TEA updates the census data. If there are any new schools that have come on board, they will have a 0 census, I think, until March timeframe. And so even though we may be bringing those schools on board, there's not that corresponding bump in population until we get that census data later in the year. And so there are some shifts in the population, and you will start to see some of those shifts down here in that bottom right. So we do ask the HRIs to let us know approximately when they're planning to onboard the different schools. And it does look like we have about 213 from the August report that they were planning to onboard in September. So as we get that September data, we will vet the plan numbers with that and then update October and other months based on the information they give us. This is just a different view of that ESC level information, Education Service Center, showing where we're live, where we're struggling to get a response, which regions have declined services, and what's left to be reached out to. And this is just a growth curve showing the population covered and the number of schools that have been covered since we first started tracking. And again, making really good progress here. And then finally, these are the reasons that have been provided to us by the districts, why they're declining TChat services. We don't always have a response, but majority are because they have existing mental health providers or an existing telehealth or app that they think is serving their population. There are some school districts in which we have MOUs, but they have decided not to move forward with TChat services at that school level. And so this is something new that we started tracking, and you can see it's almost a third, 30%, where we are having those districts say, we want TChat for these schools, but not these schools. Again, they can come back and change their mind later if they want, but for now, that's one of the things that we're seeing. And that's all I have for this. If anybody has any questions, I'm happy to answer.
Very good. Any questions for Lachelle? Trina?
Thank you, Lachelle. I'm curious about that last bit of your presentation where you talked about declining some schools in the district. Did they tell you why they're accepting in some and not in others?
It's not in the data that I'm receiving, but I have heard from people, some of the HRI staff, that sometimes it's elementary schools and they don't know that it's necessarily needed at that elementary level, and they're focusing more on the middle and high school levels. But again, we have seen some shifts where people declined previously and now they're wanting those services. I think they're starting to see some trends and reaching out to us. So we'll continue to monitor that.
Any other questions? Again, we're seeing good progress. I think, you know, that this wasn't going to occur overnight, going to 100%, but we're reaching close to the point where it's been offered to everybody. And we have some that have declined, or some that are MOUs are pending, has to sign off. Some of these, you know, certain schools and not other schools, where institutions are getting close to where any school in their area has been offered the program, and then in the process of getting them signed up. And I think we're also seeing progress in that salmon colored area on that first chart of schools that were on the onboarding process. That those numbers have decreased substantially. And part of that is getting better clarity, because sometimes some of our institutions have reached out to some schools over and over again, and they just don't get a response. And so that's not on them at this point. They're doing everything within their power to make sure the schools know that it's available. And so thanks to our friends at TEA and the educational service centers, again, would again solicit your help to make sure that the schools in throughout the state know that it's available, free of charge. And if it fits into their system, we want to make sure it's available. But sometimes there are good reasons why it doesn't fit into what they have at this time. Dr. Ida?
Just one other question. Do you see a greater uptake in the rural areas versus the urban areas? Because there tend to be challenges around getting access to services in the more rural areas. So I'm just curious if you see a difference there.
Our internal evaluation team and our external evaluation teams have been looking at the uptake of services compared to the general population across Texas. And it's been, there has been good uptake of TChat in those rural areas. the data I have is from last year. They're in the process of finalizing their year-end report. But nothing that I've received has indicated that that's gone away. I think there's still a high demand for services in those rural areas, just given that there's not much around, and this is a way for them to connect their children with care.
We've seen significant, and you kind of touched on it, is that if you look at number of consults by like 100,000 individuals, is much higher in rural areas than in the urban areas. And it seems like it was 3 times or more higher in the rural areas than in the urban areas. Any other comments?
Dr. Martin or Dr. Wakefield, any of y'all from rural Texas or frontier Texas want to talk a little bit about that? Or no, I mean, I hate to call on you if you didn't know you were going to have to talk.
That's fine. Yes, I mean, that's what it seems like in our area. The rural folks are much more interested, much higher utilizers. The school districts that we a lot of the 2 of the school districts in particular that we would really like to sign up, but they haven't signed up or haven't. One of them, they just haven't completed the process. The other one, we have an existing in-person clinic, but we also want them to do TCHAT. They're both urban. They're both inside of El Paso County and not in one of our rural counties. So it definitely holds true. And then there's also this population that isn't so much covered by TCHAT that we have some private funding for separately with our psychology division and for young adults. So, because those once they're not school age, they usually don't get their Medicaid anymore unless they're severely impaired. And so they are a group that is doesn't have many places to go for mental health care.
Yeah, and I was going to say something similar, that we have great uptake. People want to use these services, especially when they have incorporated them into their workflow. So year over year, we're seeing more and more referrals from even the schools that we've engaged previously, because they get more used to the service and we build that trust. But what we see, I think, more in rural than we see in urban areas is that there's no one to, or very few people to refer to out of the service. And so we often are the only service within a community. And so when we're looking for options for referral outside of that community, and it's not a kiddo who qualifies for a local mental health authority, then there aren't additional services in that community to refer to. So we struggle with that referral out of TCHAT.
All right, any other questions? Seeing none, again, thanks, Lachelle and everybody. Let's move to the last item on our agenda. Dr. Cesar Sotero, you want to give us an update on the town hall that you had at UT Health Houston?
Hello, everybody. I'm Cesar Sotillo. Nice to be invited here as this executive committee. I won't wait for the slides to come up. We had a few slides. Thank you, Lachelle. All right. So, okay, so this is a very brief update on the town hall that we had, and we call it the UT Health Houston Texas Child Mental Health Care Consortium Town Hall. And we had that on July 21st. And we wanted to, the objectives were to introduce our teams to the community and show them our programs through the SB 11 initiatives, CIP and TCHATs and CPW, and also the ARPA extension projects, because there's too many acronyms and the community doesn't understand what we're doing. And so we wanted to make sure that they were knowing which one is which and how they could access us. And a little bit also present some results and mostly resources. And also have a space and a time for all the teams to meet and reflect and see us together in the same lecture hall, kind of to gather ideas among ourselves and what things work, what things didn't work, and how to move forward. So next slide. So the first was to introduce our leadership team, and of course our two members of the executive committee, Dr. Jerry Suarez, our chair, and Dr. Taiwo Babatope, who's also a member of the executive committee, and then Mary Lopez, our director of management operations, and myself as vice chair and chief of child psychiatry. Next slide. And this was the agenda that we went through. We show them what we are doing through our CPAN project. Then all the programs that are through TChat as well. Next slide. And then the ARPA extension through TChat, including the extra regions, extra sessions, the youth aware of mental health, the substance use program, anxiety, and the trauma related services. And then next. And finally, the CPW, the workforce expansion, including the psychology internship, the social work fellowship, and the LMHA. And these are the programs that we have here at Houston, because you are different HRIs, you're participating in different projects. But these are the ones that we are involved with. Okay, next slide. And I took the time to look at who came to our meeting. We had 186 persons who attended. 46% attended in person. And they listed 60 different job titles. So I took the time to kind of try to group them, and I more or less grouped them into clinical. So we had like 41 counselors and clinicians, 13 therapists or social workers, 19 physicians, 7 psychologists, and 7 community health educators, 6 nurses here on the left side. And we had some people from leadership as well, including the executive director of the Mental Health Consortium and other leadership key people, medical directors, CEOs, also trainees, both in psychology, postdocs, fellows, and interns, and also in some research assistants from our programs and outside agencies. Finally, other team members with different denominations, administrative or patient access representatives, and finally people from the school, including different kind of teachers or school principals. So we had a variety of a widespread variety of people that we access throughout the community, not just like in the university, but outside the university. Next slide. And this is just an example of one of the slides. We wanted to show what services are we offering, what is the geography. So we show them here on the map of Texas, and then the map in our region. I highlighted to them that we cover a region, for example, with our teacher services that is about 4 times the size of Paris, France, not Paris, Texas. All right. And we don't realize that, you know, our region here in Houston is similar to the surface and higher than the population of Belgium. So, you know, it's pretty remarkable how far we can access and we can help these patients. And here you have a picture of our TChat teams that for the first time we're together, like after being online for so many months. Next slide. This is another example. So we wanted to show through the LHMA where are our services, and in this case, Spindletop and Frank County Behavioral Health, what services we have, the days. And, you know, we had like 2 sites within this Spindletop in Beaumont and in Orange County that are quite far from central Houston. And then who was the doctor and the program manager, so that they could put a face to the name. Next slide. And then we also have like an exhibit hall where people could interact with our team. So we have our YAM team, the Youth Aware of Mental Health, some of the TChat main staff, like the medical director, Dr. Ali Taha, and other people, and also our team from CPAN and other teams. We had like 5 tables, and it was quite a bit of traffic and interaction with them. we got not only questions, but a lot of referrals from schools and questions about ASAP, referrals regarding some overdoses with fentanyl that they had in a little bit north of our region, including also job applications and some other networking for further referrals. And I think this is my last slide. So next slide. Yeah, and that was it. At the end, we took a picture of everybody who was involved in giving the talks. So it was a great day, and I don't know if we'll do it again, but we got a lot of good participation. So we probably will do it again, like after a few months. Thank you very much. If you have any questions or comments.
I just want you to know, Cesar, that Dr. Babatope was nodding her head that yes, indeed, you will have another one.
Okay. Well, we were wanting to do it for a couple of years, and then until one day Mary Lopez said, "This is going to be the year." And you know, Luan, who would try to scramble together to get everything ready, all the approvals, the slides, all homogeneous with the background and everything, so that it looked nice. So thanks to everybody also in the central team for helping us.
Cesar, did you were you able to quantify what a bump you got in participation in your programs?
We haven't analyzed that, but we got several referrals, and we will have to have a better look into that. But we haven't actually analyzed that.
Thanks.
Thank you, Dr.
Question, Cesar, you talked about GChat and YAM. Just your experience. How are you connecting the two?
As TChat. Well, YAM and TChat sometimes work together because we have a lot of questions from the schools, and they sometimes get confused one with the other. And sometimes we go to a school that is not part of TChat, so they are aware of the other program. So I think the other connection that we often do is the YAM with specifically the ASAP program, the substance use program as well. So sometimes it only takes going to a school and showing them what we are doing, and then that opens their eyes, and then you show them the portfolio, and if they're not participating, you get a lot of questions going. So I think they help each other and they interact well.
All right,
Thank
very
you,
good.
Dr. Billy.
Any other questions? Seeing none, thank you, Cesar.
Thank you.
And thanks for the ongoing work. And again, thanks to everyone at all 12 HRIs that are part of the consortium for the ongoing work and building out these programs. I think we're at the end of the agenda. I don't think there's anything else that we need to touch on. In which case, again, we will adjourn and give everyone back about 45 minutes and reconvene. Luann, the next meeting date?
No, November 13th.
November 13th. Very good. Well, thanks everyone.
Thanks,
Thank you all.
Dave.
Thanks a lot.
Thanks, Ken.